Thank you for joining us. We have a very exciting program today. My name is Eric Donnenfeld, and I'd like to introduce our program, Changing Landscape of Management in Eye Diseases, Glaucoma, Ocular Surface Disease, Neurotrophic Keratitis, Cataract Surgery, and Vitreoretinal Surgery. We have a pretty amazing faculty today. We have Nyan Lee, who is an assistant professor at University of Texas, Kishan Patel, who's at also University of Texas, Ian Pitha, who's our glaucoma specialist. He's at Moran. And then we have Walter Whitley, who I've known and lectured with many times and is an outstanding lecturer as well. And he's at Mid-Atlantic Eye Care Partners. This MedNet program, I first of all want to thank MedNet for helping us put it together, has received commercial support from Alcon Vision and Dompe for the activity and in the form of an unrestricted educational grant. And this is the accreditation. And thank you again for attending. And to receive your CME or CE certificates, please ensure that you attend the entire webinar. Afterwards, complete a brief evaluation, download your certificate using the link, and complete the evaluation by May 15th, 2006. We will have disclosure of unlabeled use. And the disclaimer is that the information presented here needs to be evaluated by you when you look at the program, just as you would any educational program. In accordance with ACCME standards, we've evaluated the program, and this is a CME program. And we have several very interesting and important learning objectives, and that is to summarize clinical presentation, topical agents, sustained release drug delivery systems, and surgical approach in managing glaucoma, the ability to assess the tear film's integrity, corneal homeostasis, and ocular surface disease, to interpret testing procedures, artificial tear formulations, and neuromodulation in managing ocular surface disease, to outline the diagnosis and emerging treatments for neurotrophic keratitis, which is an extremely important topic, appraise the type of cataracts, imaging, and innovations in cataract surgery, and outline the complications of cataract surgery and management by a vitreoretinal surgeon. And here is our agenda. We're starting now with Ian Pitha, and then we'll go on to Walter, myself, Nyan Lee, and Kishan Patel. And with that, I'm going to turn the program over to Ian, who'll give a pre-test vignette. I'm going to stop sharing and let Ian take over sharing of the screen.
All right, can you see that slide there? Is that showing up well?
Yes.
Okay. So a 52-year-old woman, well, thank you very much for attending and putting up with my presentation today. I'm really excited to present. It's a lot of information, but I've tried to highlight a few things that I think are really important in glaucoma now. So we have a 52-year-old woman who presents for routine eye exam, strong family history of glaucoma. Her father and older sister both required glaucoma surgery in their 60s. No visual complaints, and her intraocular pressures are pretty normal. They're 14 to 18. Her visual acuity is 20/20. Central corneal thickness is 480, so a little bit thin. And her optic nerve imaging shows a large cup to disc ratio with inferior thinning of the neuroretinal rim. Humphrey visual field testing reveals an early superior arcuate defect in the right eye. So what do you do? Do you observe and just repeat testing in 1 year? Do you start a treatment to lower the IOP and have a goal of about around 30%? Do you suggest some lifestyle modifications, avoid alcohol, caffeine, maybe exercise? Or do you do an MRI of her brain and orbits, because this is likely not glaucoma? And lastly, do you refer for genetic testing? So those are the options, and hopefully I'll touch on the correct answer and a nice approach to dealing with this patient during this lecture. All right, so this is going to be a little bit like drinking from the fire hydrant. It's all of glaucoma in 25 minutes. So let's get started. These are my financial disclosures. None of them are relevant to this presentation. So today I'm going to go over, most importantly, I think, a really good definition of glaucoma, its epidemiology, and how we diagnose it. I'll touch on glaucoma medical treatment, talk about drops in some of the newer sustained release medications that we have available to us, and talk about one of the laser treatments that is picking up recently in glaucoma, and talk about surgery. I'm also going to touch briefly on lifestyle modification on glaucoma at the end of this presentation as well. So glaucoma epidemiology, diagnosis, and risk factors. Glaucoma is very prevalent. It's the second leading cause of irreversible blindness in the world, and as populations age internationally, it's only going to become more and more prevalent. So it's an important disease to keep in the back of your head when you're seeing your patients. There are basically four different types of glaucoma: open angle closure, childhood glaucoma, which is extremely low prevalence but has a high impact because most glaucoma, primary glaucomas, patients live with for about 15 years before they die. Childhood glaucoma, they're really living their entire lives with the glaucoma, so decades and decades. And then there's the secondary glaucomas that are secondary to things like diabetes and uveitis and steroid treatment and a number of different things that can happen or that we do to our patients. You look at the global distribution of blindness due to glaucoma. This is kind of, at least in the United States or in North America, a reassuring slide in that, most patients, or the overwhelming majority of patients who develop glaucoma, don't end up going blind from it in the United States. I think that's an important thing to stress with our patients, as the diagnosis of glaucoma, at least in some populations, carries with it kind of this assumption that they're going to go blind at some point. So I always try to stress that with my patients. The definition of glaucoma. So if you're going to pay attention to 10 slides of this presentation, I would, pay attention to this one or these 10 slides, because I think this is a really important thing to really hammer down. The glaucoma is defined by the structure of the optic nerve and its effect on function. Pressure is not part of the diagnosis of glaucoma. By function, I'm talking about your visual field, right? How is the peripheral vision affected by this disease? And by structure, I'm talking about the structure of the optic nerve head, where it plugs into the back of the nerve. This definition has existed for a long time. And it's considered the gold standard of definitions for glaucoma, but does not include pressure. So in glaucoma, you have a very characteristic appearance to the optic nerve head. You have cupping, right? So in this nerve, you see a cup to disc ratio of about 0.6 or 0.7. And kind of a red flag in this nerve for glaucoma is the notch that's seen in the superior part of the nerve. So you can't have glaucoma without a characteristic appearance to the optic nerve head, which is cupping or excavation of the optic nerve head. And then you have characteristic visual field changes. And those are usually detected on Humphrey visual field. They're completely asymptomatic unless you're at the very late stages of the disease. On the left side, you have your normal visual field. On the right side of that slide, you have what we characteristically tell people, or most patients assume are their visual symptoms from glaucoma. You get this tunnel vision. And, that might be present at the very late stages of disease, but I think it kind of does a disservice to the actual visual field changes or visual experience of our glaucoma patients. Because the more and more we learn about the way glaucoma affects your vision, we know that the brain is this inference machine. It tries to fill in missing information with our best guess. So if you see a normal visual field on the left side of that screen, you have the natural blind spot shown there, but no glaucomatous visual field defect. They're kind of seeing the whole picture there. If you have a glaucomatous visual field defect, which is seen in the superior arcuate defect on the right side, they're not really, patients aren't seeing dark spots or blurry spots there. Their brain's really just filling in the blank, and it's probably filling in the blank with what it expects to see, which is just the rest of the road. So instead of seeing a blurry spot or a dark spot there, what patients usually are probably experiencing is just the brain filling in something that it expects to see. I think this is a little bit of a dark slide example. getting out the lady with the suitcase, but I think it's a very illustrative of, you know, how our patients actually experience glaucoma when they have those visual field defects. There are a number of known risk factors for glaucoma. They're not the same in each person. They're not causes of glaucoma. So risk factors aren't causes, they're just associations. If we look at primary open angle glaucoma, its risk factors are very illustrative: age, IOP, genetics, blood pressure, diabetes, race, and then certain factors of the eye, optic disc size, the degree of myopia, and central corneal thickness are very important risk factors in developing glaucoma. The most important risk factor in developing glaucoma across all populations is aging. The frequency and prevalence of glaucoma increases in all populations as patients age. This is true for primary open-angle glaucoma and primary angle closure glaucoma. Of course, not true for juvenile glaucoma or pediatric and secondary glaucomas. But it's a very important risk factor for glaucoma development and progression in basically every population out there. The relationship between IOP and glaucoma is very complicated. As glaucoma specialists, we think about this a lot. But the most important thing is IOP levels do not classify an individual as glaucoma or not. It's that structural change and the functional change in the Humphrey visual field. Why is this important? Because if you look at IOP distributions across normal populations and glaucoma populations, you see there's a lot of overlap. So in this slide, if you just look at IOPs above 21 as diagnostic of glaucoma, and that was your definition, you'd be missing about 50% of the glaucoma patients that are out there, and you would be over-diagnosing a large number of normal populations who will never develop glaucoma. It might be worth following those people, but certainly not treating them if they don't have glaucoma. So again, it's a complicated relationship. Population surveys in multiple different populations show that 50% of those with open angle glaucoma rarely have an IOP greater than 21 millimeters of mercury. So if you were just using that as your definition of glaucoma, you'd be missing about 50% of the cases that are out there. So glaucoma screening, it's really not used in a widespread fashion for very good reasons. The sensitivity and specificity of current screening mechanisms really aren't to the level at which glaucoma screening is effective or economically viable. But if I was going to give you several recommendations, I'd say older patients should all have eye exams. Look at the nerve and don't become overly reassured by normal IOPs. Ask about family history. If they have a first-degree relative with glaucoma, they should get screened for glaucoma. And if you have a patient in your chair with glaucoma and their son or daughter or sibling is with them, their sibling should get screened for glaucoma. There's something that's coming out right now called the polygenic risk score, which is actually available, which can help assess risk for glaucoma. It is something we're probably going to be instituting and using more widely in the next several years. It's just starting in the United States. It looks at a number of different risk factors and can give you a number of what your risk is for developing glaucoma. So glaucoma treatment, we just lower the intraocular pressure. That's it. Works for all types of glaucoma. And our goal is to attain a healthy IOP for each patient. And there are many ways to do it. There's this classical approach that we used to take where you'd kind of see a patient, diagnose them, start them on a drop. If that wasn't working well enough, you'd add some drops. If that wasn't working well enough and they were getting worse, you'd do a filtering surgery like a trabeculectomy or a tube surgery. Once that failed, you'd add some drops. And once those drops failed, you do some more surgery. And it kind of was this cycle that was very linear. But more recently, I'd say in the past 12 to 15 years, our algorithm has gotten increasingly complex. When patients present, we can do laser, we can do a minimally invasive glaucoma surgery, we can start them on drops. And if those stop working, we have a number of different options. So you can see that the kind of path that each patient takes has gotten maybe exponentially more complicated. So we have options. I think this puts an increased burden on medications to be effective, to be safe, and to be free from side effects. But medications are still the overwhelmingly popular choice for initial treatment of glaucoma in our patients. And there are two basic approaches, right? If you think of IOP as the fullness of that bathtub, you can either drain fluid from that bathtub, or you can kind of turn down the faucet of what's filling it up. And that's what our drops do, right? We're very lucky to have a lot of good options in kind of medical and topical treatment of glaucoma, and a lot of good generic options as well. First line treatments tend to be prostaglandin analogs and beta blockers. But once we talk about second line treatments, we can talk about alpha-2 agonists like brimonidine, carbonic anhydrase inhibitors as well, and any number of combinations between the two. If your patients are intolerant to those medications, we also have preservative-free versions available. Tend to be more expensive, but they're less expensive options from compounding pharmacies that are available. And then we have a number of new medications that are out there that are currently on patent, tend to be more expensive, but can work very well. Those include the Rho kinase inhibitors, which is notarcebital or Ropressa, and nitric oxide conjugated drugs such as latanoprostene, Bunode. They all tend to measure or lower the pressure effectively, and they target different mechanisms of IOP reduction. But drops are really limited. Sometimes they don't work well enough. There's a lot of issues with medication adherence among patients. There's also significant surface toxicity that a lot of our patients have, as well as systemic side effects, especially with beta blockers and alpha-2 agonists. They tend to cost a lot. They're generic, but over the term of 10 years or 15 years of taking those drops, the accumulated cost can be quite high. And for a lot of our patients, especially ones with rheumatoid arthritis or Parkinson's, they can be really difficult to administer, even with drop aids that are available on Amazon. So how do we deal with this? So one thing to deal with is medication adherence. There have been a number of different approaches to develop algorithms to identify our poorly adherent patients and introduce strategies such as reminders or phone reminders to tell our patients to take their drops every day. I've done a considerable amount of work on developing alternatives to daily drop administration. And the alternatives that I'm really interested and excited about in ophthalmology are sustained release medications. And this is the basic concept of what a sustained release medication does. On the y-axis of this graph is tissue drug concentration. You can see there's a therapeutic window that you want to hit. If you go above it, you're increasing side effects. If you go below it, you have really poor activity of the drug. And on the x-axis is time, which goes from minutes to really months. So when we give drops, we're really giving a pulsed delivery where we're giving a very high concentration of medication on the surface of the eye in order to get within the therapeutic window at the target tissue. So the delivery occurs over 2 to 5 minutes, and the therapeutic window probably lasts between 6 to 24 hours. And that's why we have to administer drops several times a day to daily. The concept of controlled release medications is you administer the medication once, and you can deliver that medication to the tissue, the target tissue, for a really sustained period of time, from weeks to months to potentially years after one administration. Not only do you overcome adherence issues, but you spend a lot more time in the therapeutic window without the increased side effects from pulsed delivery. And there's been a lot of interest in clinical development of sustained release medications. I've shown a number of examples here, from implants that are injected into the eye to punctal plugs, and even a ring that kind of goes in the fornix of the eye and kind of releases medication over a period of time. Also, some work in contact lenses as well, which is very interesting and promising. If we're looking at what's actually clinically available, From Obvi, we have the Bimatoprost Sustained Delivery implant called Durista. It's an intracameraly injected implant made of PLGA. It delivers 10 micrograms of bimatoprost, which is essentially the amount of bimatoprost in one eye drop, but it delivers it over 4 months. And it reduces exposure to off-target tissues and works very well at lowering IOP. There have been issues with endothelial cell loss in some of these patients, but it's currently clinically available for our patients. And more recently, there's a travoprost sustained delivery implant, which actually gets kind of injected into the trabecular meshwork and placed into the trabecular meshwork in the OR. And it has a longer duration of efficacy, usually 6 to 12 months. It should last over a year. It's placed in the operating room. And a nice thing about this is it's secured anatomically within the eye, so there's at least theoretically less of a chance of endothelial cell loss. This is available now clinically, quite expensive for our patients. I think with a price of well over $10,000 per implant, which can be covered by insurance, but it's been released by the FDA and cleared by the FDA and use at least over the last year in the United States. So moving from medications to laser treatment. So they're basically, three different ways that we treat glaucoma with lasers. Selective laser trabeculoplasty or just laser trabeculoplasty, which could also be ALT. We do laser peripheral iridotomies. And then in the operating room or the procedure room, we can do transscleral ciliodestructive lasers. There are a number of other lasers that are available, but these are the three main ones that we use. And I really want to focus on SLT today because there's a renewed enthusiasm on using it as an office-based procedure to lower IOP. So there was a trial called the LIGHT study done out of the UK, prospective treatment, naive patients with glaucoma, ocular hypertension, and they compared medical treatment to SLT. And these UK studies used the primary outcome. It was healthcare, health-related quality of life at 3 years, but they also looked at IOP and a number of different outcomes. And what they found was SLT was really cost-effective and no difference in quality of life and clinical outcomes compared to medication treatment. And at 3 years, 78% of the SLT patients were off drops, and they were at target at 36 months. So that's very effective at lowering IOP. And what they also found was that drop treatment was associated with increased side effects and cataract progression over time when compared to SLT. So they followed this study out to 6 years, and it continues to be promising. The majority of the SLT patients remained controlled off of IOP drops, so they didn't have to fill a prescription. They didn't have to put a drop in their eye every day, which to me signals increased quality of life. And it was also an effective means to stop drops in patients who were initially on the medication arm. So there's a bit of crossover there of people choosing to go off medications and have their IOP controlled by SLT. So because of this study, we're really offering SLT as a first-line treatment more and more frequently in the United States. But SLT can be uncomfortable for patients. It's a procedure. They have to come into the operating room, have to put their head in the slit lamp and have a lens placed on the top on their eye and undergo a procedure that usually takes between 10 and 15 minutes. Because of this, there was inspiration by a group to develop something called DSLT. So in SLT, we use a gonio lens to direct laser to the trabecular meshwork. DSLT uses the concept that, hey, let's just hit the trabecular meshwork through the cornea using the same laser without having to use the lens. So more recently, there's a device called the DSLT. It's non-contact SLT that's now distributed and used by Alcon that allows a patient to put their head in this device and essentially have an SLT procedure performed on them over 5 to 10 seconds or less than 5 seconds because there's automatic recognition of the limbus and of the target by this laser. So this is something that's available that we're using at the Moran now over the last year or so. There is a click fee, so we do have to pay the company every time we use the device, but it's an interesting option that you might be hearing of in the future, as well as it potentially gets picked up in different practices. So talk a little bit about glaucoma surgery as well. Again, two basic approaches. Either increase the drainage or decrease the ciliary body's production of aqueous fluid. The traditional approach that we've used is called filtering surgery, where we're either modifying the structure of the eye to create an outlet of fluid to drain from the anterior chamber into the subconjunctival space. That's called a trabeculectomy. Or we're implanting actual devices, tube shunts, to create that vent. And what those basically do is create a vent for pressure to be released from the anterior chamber to the subconjunctival space. There are a number of complications that are potentially associated with this, and recovery time can be quite lengthy from these surgeries, but they're really a great option for our patients who are at risk of going blind from glaucoma. The major concern we have after these surgery is that fibrosis is basically going to plug that vent. So it's a major cause of failure, causing 40% of tube shunts to fail within 5 years and 30% of trabeculectomies to fail within 2 years. So that's a constant concern among glaucoma specialists, and why these patients, even after the surgery, should be followed closely to monitor the success of their surgery. But in the past 15, 20 years, we've had the fortunate development of minimally invasive glaucoma surgeries, and there's been a lot of interesting devices that have been developed. These are very small devices. The Hydrus is about the size of an eyelash. I think the eye stent shown there is the smallest implantable device that's put in humans. And then these are usually implanted at the time of cataract surgery, but can be implanted as standalone procedures. They use a lot of innovative designs, new materials like nitinol or gelatin, and elegant surgical approaches and inserters. And they often offer very quick recovery time. So they reduce the risk and they offer rapid recovery. They do lower IOP, but to a lesser extent than our traditional filtering surgeries. So they're a great option for a lot of patients who need a little bit of IOP reduction or a little bit of help, but not always the best option for people who are really at risk of going blind from glaucoma and require a substantial IOP reduction. And lastly, I want to talk, wrong direction. Lastly, I want to talk about lifestyle modifications, because I get this question all the time, right? What can I do to fix this? Part of the reason I became a glaucoma specialist is because I thought I wouldn't have to talk to patients about lifestyle modifications. But there's some evidence that lifestyle modifications can help our glaucoma patients. Stress in glaucoma. Every time a patient comes in with a higher pressure, hey, my pressure was high today, but I'm having a lot of stress in my life. Do you think that could be related? I'll tell you, 99 out of 100 patients can't be wrong. I think there's something behind this. Stress certainly affects medication adherence. There's a lot of clinical evidence on this. And there's really growing evidence of a causal relationship between chronic stress and acute stress and IOP. This is shown in animal models and some really elegant randomized clinical control studies. I'd say yes, there is a relationship. If you can reduce the stress in your life, you might see some benefit. This IOP elevation that we see today might be, stress might be contributing to it, but I'm still concerned about it, and we have to deal with it because we have to deal with your disease with the stress in your life. Exercise, I think there's kind of the strongest lifestyle evidence for a beneficial effect. Is this going to be the event that initiates a healthy lifestyle for a patient? Maybe, but what I basically tell them is, your primary care doctor is telling you to or asking you to meet certain kind of exercise metrics every week. There's a lot of basic science evidence that mitochondrial health plays a role in glaucoma. We know that exercise lowers your intraocular pressure. It could also be neuroprotective. So make efforts to exercise and kind of do moderate to vigorous activity for 20 to 30 minutes, 3 to 5 times a week. That's a high metric to meet, but it could benefit you. Smoking and alcohol, I used to tell patients there really was inconclusive evidence, but they should make choices that are beneficial to their overall health. Now I'm saying, hey, there is some evidence that smoking and alcohol cessation could help with their glaucoma. Less strong evidence with caffeine, though. And then lastly, vitamins. Yeah, eye vitamins, there's no substantial evidence that there's a beneficial effect. Ginkgo biloba and herbal extracts, there's some preclinical data, but there's no really strong clinical data. And then there's some trials going on with neuroprotection and vitamin B3, nicotinamide. So I say, keep your we'll keep up on those studies, but I'm not recommending doing that yet in most of my glaucoma patients. So to review, we've looked at the glaucoma definition and epidemiology, some of the medications, talked about lasers in glaucoma, but mainly SLT, little bit on glaucoma surgery, and then lifestyle modifications. And there's more and more evidence that lifestyle modifications could help glaucoma, but those really parallel the lifestyle modifications people should be doing to maintain their overall health, healthy body, healthy eye. All right, so thank you very much. Let's go back over this clinical vignette. Again, we have this 52-year-old woman, routine eye examination, strong family history of glaucoma, first-degree relatives with glaucoma, no visual complaints, normal IOP, perfect vision, central corneal thickness is a little thin, but the optic nerves in the Humphrey visual field look like glaucoma. So how do we treat this patient? Again, the options were observe, nice. Start treatment, topical prostaglandin to lower IOP. Recommend some lifestyle modifications. Do an MRI because this doesn't look like glaucoma. Her normal pressures in Humphrey visual field probably say that there's something going on with the brain or the optic nerve that you need to see, or refer for genetic testing. The correct answer is, this is glaucoma, and which is defined by Humphrey visual field and the appearance of the optic nerve. So I would start treatment. I would actually be discussing either prostaglandin or SLT. Observing with repeat testing, I think in 1 year is a little too distant, but if I really wanted to hammer down that this was glaucoma and she didn't want to start treatment, I could repeat the Humphrey visual field in several months. But I'm really treating this as a definitive diagnosis of glaucoma. She's going to ask about lifestyle modifications. I would certainly recommend that. I think an MRI is too much, and we don't know the place for genetic testing in this patient yet, although it might be something that they want to do in the future. All right, so I'm going to stop sharing right now and pass it on to the next presenter. Thank you very much for your attention. Great job on the test.
All right, perfect. Hey, well, good morning, everybody. Thank you for being here, and thanks for the opportunity to present today. Before I get started, we'll go over the pre-test clinical vignette. And so here we got a 64-year-old white female presents for a dry eye follow-up with MMP9 testing, constant and moderate dry eye symptoms of burning and tearing. Vision fluctuates daily, has been on cyclosporin 0.05% on and off for a couple years. Tried plugs in the past, but they fell out. You can see the ocular history of styes, amblyopia, medical history, medications, as well as allergies that this patient does have. When we look at the clinical examination, the vision, you can see there, the speed score, 24. We know the highest score you can have here is going to be a 28. Looking at the slit lamp, had 2+ MGD, cloudy secretions upon expression. There was no telangiectasia, no staining, no Lisman green staining, tear film breakup time about 3 seconds and 4 seconds, and tear meniscus height about 0.3 millimeters. If we look at the tear osmolarity, 306 and 302, and the MMP9, so looking at inflammation, was negative. And so after all that, check the pressure. Pressure was about 13. So based on the clinical presentation, what component of the tear film is most likely compromised? Whether it's the mucin layer, aqueous layer, lipid layer, and the biofilm, and everyone can pick a choice. And so that's what I've been charged with today, is going to talk about the overview of the tear film and its role when it comes to ocular surface disease, as well as corneal conditions, and where does that fit in. And so y'all can go ahead and vote there. And I'm pretty sure you have a good idea of what the answer may be. And so, overview, let's just break this down. I mean, we talk about, when it comes to dry eye, we often talk about, the diagnosis, the numerous treatment options. And it's an exciting time when it comes to ocular surface disease, because we have so many more options that we have now than we did in the past. And Dr. Donnenfeld is going to talk about that here after my lecture. But here, what we're trying to do is just set the stage, all right? And where does a tear film play? What's the role in developing homeostasis? We always hear about tear film homeostasis, but for conditions that we're learning more about, such as neurotrophic keratitis or neuropathic corneal pain, we need also corneal homeostasis. And so making sure that we're evaluating this. Right now, it's the TFOS DUES 3. I'm not sure who's read that so far, but we'll give you some highlights of some of the sections where it's pertinent to this discussion, and then I'll talk about some diagnoses and then turn it over to Dr. Donnenfeld. My name is Walt Whitley. I'm the Director of Professional Relations and Education at Virginia Eye Consultants in Norfolk, Virginia, large tertiary referral care practice, and I do oversee the dry eye clinic within the practice. Here's my disclosures. Work with several different companies, or actually numerous companies within the dry eye space. And this is what we're going to go over today. All right, the purpose of the tear film and the ocular surface unit. We know that it protects, nourishes, and maintains the transparency of the cornea. We know that it serves as the first refractive surface. 2/3 of the focusing power of the eye, we know, is at the tear film corneal interface. And so we need a healthy tear film to provide our patients clear, comfortable vision, whether it's going to be with glasses, contacts, surgical procedures as well. We'll define functional integrity and look where the lacrimal glands, the ocular surface, both cornea and conjunctiva, the meibomian glands, lids, and sensory nerves, where these all fit in. You've heard about the lacrimal functional unit, and we'll talk about that in a little bit more detail. And so the objectives: understand the tear film structure and function, and how corneal homeostasis is maintained. The tears. We're all familiar with this model. We know the various layers of the tears. Sorry, I'm trying to get rid of that chat. The various layers of the tears. But before we get into that, we know that the tears is on average about 3 to 10 microliters in volume. We know the thickness is 3 micrometers thick. The turnover is about 1 to 2 microliters per minute, and that the pH is going to be close to 7. If we look at the various components, we know that the tear film, we need the mucin, right? Because we have a hydrophobic cornea, and so we need something that's going to attach the tears onto that corneal surface. And so the mucin layer, which is formed by the conjunctival goblet cells and the epithelial cells, this helps stabilize the tears onto the glycocalyx to attach onto the surface. And so we know that this provides viscosity and stability during the blink. We have the aqueous component. So this is going to be the majority of the tear, where this is produced by the lacrimal glands. And it has its mixture of proteins, metabolites, as well as electrolytes. And we need a good portion of that to maintain our healthy vision and clear vision. And then the lipid component. There's over 600 unique proteins into the tears in the lipid layer. But is the outer layer, majority, about 70%, is secreted by the meibomian glands. We know that this does prevent evaporation, but also provides a smooth surface for the cornea and for our vision. So without all these layers in check, that's when our patients can have all these issues, whether it's going to be blurred, fluctuating vision. We know the most common reason for patients to come into our practice is for blurred vision. Well, tell me more. Is it always blurry? If it's always blurry, we know that that's a refractive error. Maybe it's cataracts or maybe a glaucoma. But if it changes or fluctuates throughout the day, clear, blurry, clear again, then we know that this patient has an unstable tear film. They don't have the normal homeostasis of the ocular surface to provide that vision. And so the best analogy for us is going to be the windshield wiper. Clear, blurry, clear again. If you ask our patients that, you'll find majority of our patients do have these conditions. If we look at the TFOS DUES 2, up to 50% of the patients do suffer from dry eye disease. We know that Michael Leb's data says about 86% does have an evaporative component. And so, if you have a video, you can show your patients, if it's in your exam lane, the tears breaking up, or just show them a picture. And so just say, hey, Mrs. Smith, this is what the tear film should be, nice and smooth and green throughout. But you see this black area. These dark areas is where your tears are evaporating, and it's evaporating quickly. And so something that we need to address. And that's why we're going to prescribe this, that, or the other. We've also heard of the more modern concepts of the tear film. And so instead of 2 layers or 3 layers, it's 2 layers. So we still have that lipid layer to prevent evaporation, but we do have a mixture of the mucoaqueous layer. And the entire tear film is involved in limiting the evaporation. And this occurs through the role of proteins in the mucin as well. But we have to maintain all aspects of the tear film for ocular surface homeostasis. We know within the aqueous, we do have our lactoferrin, we have our lysozyme, we have our secretory IgA as well that help protect the cornea from microbes. We know that we have the salts, we have the potassium, we have the various electrolytes that are in there. And so whenever we're looking at our tears, we want to look at the quality of tears. And so basal tears, we're all familiar with this, but this is important in ocular surface homeostasis. By having that tear with over 2,000 components to the tears, whether, once again, the growth factors, the antimicrobial proteins, the electrolytes, nourishes and lubricates and protects the ocular surface. And this is coordinated by the lacrimal functional unit. And so basal tears, many components are diluted in reflex tears. And so we know with reflex tears, especially with dry eye, patients are like, why do I have dry eye? I'm tearing all the time. And so just explaining to the patient, kind of like when you get poked in the eye, you cry because your eyes are irritated. When your eyes get dry, they get irritated as well. And so those are not natural tears, and that's why we're prescribing this pharmaceutical agent to increase your tear production, to increase your basal tears. There is a third tier that isn't really talked about much, which is going to be the closed eye tier. And so just essentially protecting that ocular surface while we're sleeping. And we know that the secretory IgA does help protect that surface. But then as we wake up and start to blink, we know that those proteins are decreased in levels. Looking at corneal innervation. And so we know that this is the most innervative and sensitive tissue in the human body. And we're familiar with this diagram here, where you have the corneal nerve that has the trophic and the protective functions to help protect that corneal epithelial cells that we know turn over about every week, 7 to 10 days. Some studies say about two weeks. And so this feedback provides the regeneration and survival of the nerve. The innervation is essential. Corneal epithelial cells are mutually supportive relationship with those nerves. As you can see on the right, the nerves maintain the integrity and the protective functions of the blinking and the tearing to wash out any irritants that may be harmful to the ocular surface. It provides the neuropeptides to promote epithelial cell proliferation, migration, and adhesion, as well as the neurotrophic factors and the growth factors to keep things moving. But any damage, anytime that corneal nerve is damaged, then we lose sensation. There is epithelial breakdown and poor healing for our patients. And so we know that the epithelial cells, that it starts with the limbal stem cells that create progenitor cells that are essentially adult stem cells, but with a limited half-life. And so these progenitors move inward from the periphery of the limbal stem cells, and that leads to the differentiation. But then the sloughing of the older epithelial cells that are going to get washed away within the blink. Innervation, we're familiar with the ophthalmic branch of the trigeminal nerve. And so this is what sends there's afferent signals to the brain, as well as the efferent back to the tissues that maintains the ocular surface homeostasis. So it does transduce pain and mechanoreception and temperature, as well as regulate the blink reflex and tear production and produce the trophic nerve growth factors that are always present, but it can be elevated in any type of injury. But over time, the nerve growth factors can be decreased, such as our patients with corneal nerve desensitivity or neurotrophic keratitis. And so endogenous nerve growth factors maintain the corneal integrity by three mechanisms. We know it acts through both high affinity and low affinity nerve growth factor receptors in the anterior segment to support corneal innervation and integrity. So whether it's the tear secretion by binding to the lacrimal glands and promoting the reflex tearing secretion, whether it's stimulating the epithelial cells or stimulate the nerves to regenerate and survive the sensory nerves. And so we need that. And so with corneal homeostasis, the epithelial renewal and wound healing, it does provide the nutrients and oxygen delivery from the tears, as well as on the aqueous humor from the anterior chamber. Barrier functions, we know there's tight junctions and the tears adhere to the ocular surface through the glycocalyx interface. The neurotrophic regulation, and so we do need a intact lateral functional unit to provide that innervation to produce natural tears, as well as immune privilege and modulation to be a defense for our patient's ocular surface. So when we're talking about dry eye, we know that sensory nerves may adapt to irritation. And so explaining to the patient, and we know that there may be a line between patients who have dry eye, so the staining, the symptoms that they're having, but then the hypoesthesia, which we see in neurotrophic keratitis. And so with chronic inflammation, that decreases the nerve sensitivity. And so with time, this elevates the pain threshold, and stronger stimuli is needed to evoke the corneal sensation. And so here's that patient, we put on whatever dry eye medication, and it's not getting any better. We know that dry eye medications, they work. So if you put them on a prescription and it's not getting any better, whether it's a steroid in a month, whether it's an immunomodulator within 3 to 4 months, then we have to take a step back, check the nerves. Is the sensation present, reduced, or absent? Looking at glaucoma, all right, corneal sensitivity was significantly decreased in dry eye and glaucoma patients. We know that patients on glaucoma medications, the preservatives are essentially a detergent to that ocular surface. And so that's why we're hearing a lot more about whether it's the SLT and the light trial that was just discussed earlier, any of the minimally invasive glaucoma procedures as well, to get the patients off the drops, get better control of the pressure, but also for quality of life and comfort for our patients. The study on bottom, mean corneal sensitivity was significantly lower in the non-Sjogren's dry eye group compared with the control group, and that's due to the changes within the nerves. We're hearing more about the various nerves that are found on the ocular surface in the cornea. We know that these corneal afferent sensory neurons detect environmental stimuli and produce a tearing response, whether it's going to be a touch, mechanonociceptors, whether it's an eyelash in the eye, or the polymodal receptors, whether it's going to be a chemical irritant, maybe an onion, or we have the cold thermal receptors that all these receptors are always evaluating the environment to help protect our ocular surface, to help initiate the blinks. But the cold thermal receptors, the TRPM8 receptors that were found on the corneal epithelium, this can detect changes within 2 degrees Fahrenheit of cooling. And as that cooling happens, then that's when more tears will be produced. And so the tear secretion is coordinated by the lacrimal functional unit, where we know the various components, the cornea, conjunctiva, the glands, whether it's meibomian glands or the lacrimal glands, the goblet cells, but then the function of the neural network to detect the ocular surface changes and produce tears through that activation. And so we've seen this diagram before, whether it's going to be the afferent or efferent neurons, that by stimulating the lacrimal functional unit, thinking about the basal tears, you stimulate the lacrimal functional unit, you can stimulate the lacrimal gland to increase aqueous, you can stimulate the goblet cells to increase mucin, but then also the meibomian glands to help increase the lipid layer. And so you'll see, I'm sure Dr. Donnenfeld will talk about a study looking at the increase in the lipids by stimulating the lacrimal functional unit. So when it comes to dry eye, we know it is initiated by desiccating stress and perpetuated by a vicious cycle of inflammation. We know that yes, patients may start with symptoms, but tear film instability leads to evaporation, which leads to hyperosmolarity, which leads to inflammation and then tissue damage. And so this vicious cycle with patients with ocular surface issues needs to be addressed. And so we do have the newer updates, the latest updates from the DEWS-3, where we have dry eye as a multifactorial symptomatic disease characterized by the loss of homeostasis of the tear film and or ocular surface, in which the tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities are etiological factors. And there's a lot of, and so within the DEWS-3, it's going to have the latest evidence-based medicine within the publication. And so definitely recommend checking it out if you're excited and love ocular surface disease. But some of the call outs, even going back to DEWS-2, is anybody can have dry eye, whether they're young, whether our patients are more mature. That whenever we're treating dry eye, we do need to address both the aqueous deficiency and as well as the evaporative dry eye and inflammation. So drops for many patients may not be enough, that you do have to do something for the lids and may need some type of in-office procedure to help increase that lipid layer and increase or decrease the evaporation. And then lastly, the neurosensory abnormalities that are still within the definition, where we're learning more about the pain, whether it's neuropathic corneal pain, where we know that the nerves are firing abnormally. And so with neuropathic corneal pain, we have two options. We either regenerate the nerves or reduce the triggers for the pain, which is likely going to be the anti-inflammatories, maybe some autologous serum or PRP drops, or amniotic membranes. So ocular surface disease, looking at the Venn diagram here, you may have the patient with the symptoms, that pain without stain. And so that's going to be one spectrum with the neuropathic pain, or patients that are staring at the computer like many of us. Each time we're staring at the computer on digital devices, we know the average blink rate's about 22 times per minute, except when we're on digital devices, then the data shows it can be anywhere between 4 to 7 blinks per minute. If a patient has a quick tear film breakup time, then we know that they're going to have lots of evaporative stress that can lead to that inflammation and cause a lot of the symptoms. On the left side, you can have the signs, the neurotrophic conditions where this leads to the loss of homeostasis. And some of these patients with signs, they feel nothing. And then we have dry eye disease that can overlap, and we know that the signs and symptoms don't always correlate. Symptoms are easy. Patients tell us the symptoms, we treat it. Symptoms were put within the definition in the TFOS DEWS-3 definition. But the signs, even if they're not feeling it, that's where we tell the patient, this is your condition, this is what we need to do to treat it. Just like if a patient has high blood pressure, right, don't know it, this is your condition, this is what we need to do to treat it. So the different types of dry eye, whether it's aqueous deficient or evaporative dry eye, we need to do something. There's an imbalance, whether it's going to be increased salt concentration of the tears with the hyperosmolarity, whether it's inflammation, then that's where our steroids, that's where immunomodulators come in. We knew that nutrition can also help with that. We're seeing lots of different supplements with EPA and DHA, but also GLA, which can help work on the inflammation internally. Exposure keratopathy, when we're looking at our patients with ocular surface disease, within my dry evaluation, I've added looking for doing the core blackie light test and putting the transilluminator with the eyes closed. Is there any exposure or transillumination? If there is, then we need to treat that exposure, whether it's going to be with ointments, whether it's going to be with tape tarsorrhaphy for our patients, because it's not necessarily a dry eye thing. It's an exposure thing that's causing those chronic symptoms. And then the other thing, if the patient has 2+ staining or higher on a dry eye evaluation, I'm already thinking test corneal sensitivity, and you can see some of these other conditions. So the mechanisms of disease, so they have ocular surface condition. Where does it start? We know that there is the biofilm and the proliferation of the bacteria releases its lipases and esterases, which increase the melting temperature of the meibomian glands, which leads to the keratinization, the decrease in lipid layer, and that vicious cycle that we mentioned. And so how do we address this? Where do we start? Main thing is to do something to address our patients. This is the diagram from the TFOS DEWS 3 that has been updated. And so in DEWS 2 is talking about, yes, we look at the differentials. You can see the various questions there. They actually modified the questions. And so asking patients, do you feel pain rather than the discomfort? So try and get that neuropathic component. They also looked at, do you have any facial flushing or redness, mouth dryness, or enlarged salivary glands? And so looking for patients with rosacea. We know that rosacea is associated with MGD. We know rosacea is associated with the Demodex species. And then you can read the other questions looking for symptoms for patients. Risk factors, what are they? Are they drops? Is it contact lens wear? Looking at the diagnosis, they simplified it with the symptoms. Instead of the OSDI, they modified it. It's the OSDI 6. So 0 to 4, anytime a patient has a score 4 or higher, whether it's severity or frequency of the condition, those are patients that we are going to address. Why symptoms are part of the definition. Looking at the homeostatic markers, looking at non-invasive tear film breakup time, whether you're using one of your diagnostic devices, less than 10 seconds. If not a diagnostic device, using our fluorescein and counting. How long does it stay on the eye in 5 seconds or less are patients that have tear film imbalance. But then looking at our stain, if we have corneal staining, 5 spots or higher, or conjunctival staining, or even the lid wiper epitheliopathy, where we get the keratinization, the buildup on the lids itself, and something we see often in our contact lens wears. So no matter what the condition, there's various subtypes. And what the TFOS DEWS 3 is they organize into different algorithms. Whether it's a tear film deficiency, if that's the case, what layer of the tears do we need to address? Eyelid abnormalities, how do we address that? But then also ocular surface abnormalities. Looking at the risk factors, numerous risk factors. On the left are going to be consistent risk factors patients have. The right, probable. Bottom, modifiable. And so with risk factors, if we could modify it, yes, that's going to be education for the patient. These are some of the things that you're doing that contribute to the dryness that you're having. And the most common example is going to be the patient on allergy medications, which we know that can dry out that ocular surface. Asking patients, what is your most common symptom? Is it itching? Is it sinus? If they say, no, it's eyes, well, let them know that the oral medication's drying their eyes out, and we do have site-specific therapy that can help you out as well. Looking at the diagnostic algorithm, mentioned that the OSDI 6, those are the questions that you can see there. The tear osmolarity, anything below over 308, or an 8 milliosmol difference between each eye would mean increase in osmolarity. or tear film instability. So roughly 308, 320 is mild, 320, 340 is moderate, and 340 or higher is going to be severe hyperosmolarity. I use this within my dry eye clinic. Just like with the glaucoma practice, we look at pressure over time, looking for stability. Same thing with the dry eye and the osmolarity. And so if patients, whenever we see them back 308, 300, 300 at a 3 to 4 month follow-up, it goes up to 340, something triggered that event. They're having a dry eye flare. We need to do something. So if they're on cyclosporin already, we may need to add a steroid, do a plug, do some type of dry eye treatment. And then on the right side, you can see the staining as well as the tear film instability for the patient. Numerous tests that are available looking at tear meniscus height, 0.2 or lower. Those, we're not doing Schirmer's. Thankfully, a lot of the drug companies, they've done it for us in their clinical studies, but just looking at that tear film meniscus, if it's scant, if it's very thin, or if it's very thick, if it's thin, we know that that patient does have a deficiency. You can use OCT to do that. We can use confocal microscopy to look at corneal nerves, whether they're the microadenomas that we may see with neuropathic corneal pain, or the decrease in nerve density with patients with neurotrophic keratitis. And so why is this important? Clinical implications. We're all judged by our patients' comfort and their quality of vision. And so that the TFOS used to for the management and therapy, and this is where Dr. Donnenfeld will come in, breaking up to tear film deficiencies, prescribing the various drops for that. Eyelid abnormalities in the middle. If they have, I know it's super small, if they have the collarettes, then we need to treat the Demodex. If they have incomplete or leg ophthalmos, we're going to have to either surgically treat that or find different ways to address that. And then lastly, the ocular surface abnormalities, EBMD, or various others. Triggers and treatment, wherever the changes happen, we do have various treatments that are available for our patient. If it's microbial changes, then we could use our antibiotics. If we're looking at tear film evaporation, quick tear film breakup time, then is it going to be something like perfluorohexyloctane? Increase in inflammation. We have numerous steroids that are available and anti-inflammatories, but then also treatments. And so it's not only one treatment, but many times we have to do numerous treatments over time for our patients. And so in summary, the tear film integrity and corneal homeostasis are inseparable. And so we need to optimize both. Any disruption of any of those components of the tears can lead to a cycle of instability, inflammation, and epithelial stress. And then understanding how these interplay help with targeted therapy for ocular surface disease. And so have any questions, put them in the chat box. If you have any questions for me, my email is whitley@cvphealth.com, and happy to answer those. And so we're going back to the post-test clinical vignette. Already mentioned the patient, 64-year-old. Anytime we see our patients, there's different call-outs that you can see, looking at the staining, looking at the symptoms, blurred vision, dry eyes, a vision disease, and so unstable tear film. Was on other drops in the past, looking at the clinical examination, which you've seen here already. And so based on the clinical presentation, what component of the tear film is most likely compromised? And so here they had no staining, there was no inflammation, there was no hyperosmolarity, but because of those symptoms, and I didn't do the lipid scan here, but evaporative dry eye, looking at the lipid layer and how we can address that. There are some there was the LipiView where we could measure the lipid layer. And so some studies showed that if they had a 60 nanometer or less lipid layer, then those are patients that are more likely to have more severe dry eye disease. Although there's other studies that show if a patient has obstructive MGD, they can actually have a thicker lipid layer than the average person's. The average lipid layer should be about 80 to 100 microns for our patients. And so, yeah, lipid layer, that's going to be the answer for this. And so now I'm going to turn it back over to Dr. Donnenfeld. Thank you.
Well, Walter, that was a wonderful presentation. I'm going to kind of follow up and we'll cover some of the similar topics, but You really laid the groundwork beautifully. And let's start with my pretest clinical vignette. Again, my name is Eric Donnenfeld, and this is a 72-year-old male with a hyperopic astigmatic refraction and a visually significant cataract. He, as all of our patients, wants cataract surgery as soon as possible. The patient has a medical history pertinent for Hashimoto's thyroiditis and would like to be spectacle independent. He's been treated for dry eye with artificial tears, but continues to complain of fluctuating vision. So he's already tried tears. He's light sensitive, he has watering eyes. His tear osmolarity is high, and Walter showed that anything over 308 is important, and anything with a difference of more than 8. So he's dry on both courses. MMP9 is positive. His tear breakup time is 4 seconds, which is low. Schirmer scores are also low, 5 and 8. And the tear film is diminished, and he has 2+ conjunctival staining and 1+ central corneal staining. And for me, corneal staining is an absolute contraindication to proceed with cataract surgery. His meibomian glands are 2+ inspissated, and he has minimal blepharitis. So we have a lot of options to consider. You consider all the following, except maybe one of these I wouldn't do. But would you consider topical lifidographs, topical lotirednol, change to a different artificial tear, topical perfluorohexyloctane, topical lotilaner? I could also throw in there topical Ultraman as well. Would be a good opportunity. But which of these would you not do? Let's see what the audience has to say in a few minutes. Okay, well, good. That was our pretest. Let's go on to our talk now, which is an overview of artificial tear formulations. And this is kind of a tour de force on tears. We all know about tears, but there are so many that are available now that it's really almost overwhelming. And we'll talk about neuromodulation, and Walter talked about that a little bit before too, in managing ocular surface disease. And I do work with a variety of companies that are in this space. So dry eye guidelines have really come into force over the last 20 years. The Delphi guideline was after cyclosporin had been approved, and then we had the Tear Film Society with DEWS 1, DEWS 2, now we have DEWS 3 coming out. The CEDARS algorithm, ASCRS has a protocol as well. So there are a lot of different choices and algorithms, but they all kind of start with a evaluation of how severe the dry eye is. Is it a level 1, level 2, level 3, or level 4? With level 1 being mild, level 2 being moderate. By the way, most of the patients who come to our office have moderate. Very few people come with mild. So when you see a patient, expect that they're going to be moderate or worse. It's very difficult for me to think of going visiting a doctor unless I have a significant problem that's bothering me. So level 1 is the most common, but we mostly see level 2. So in the treatment program for the dry eye workshop, they suggested that artificial tears be used for mild dry eye, along with education and a few other aspects as well. But for level 2, which I think is most of our patients, they say switch to an unpreserved or a transiently preserved tear and to consider adding anti-inflammatories. So tears are basically the baseline therapy for dry eye management. It doesn't treat the disease, but it certainly makes patients feel more comfortable. And even people who are on more significant therapies are almost always going to go back to tears when the tear film breaks down. So if you look at Medicare beneficiaries, dry is the most common ocular condition for Medicare beneficiaries for both optometry and for ophthalmology. And during the last decade, the recognition of dry eye has really been outstanding. And as Walter showed, that there are 3 different layers, or 2 different layers, depending upon how you look at it. The lipid layer and then the aqueous and mucin kind of merge together. Ocular surgery disease is underdiagnosed. There are an estimated 55 million Americans with dry eye disease, and probably more than that, with the great majority of them having been undiagnosed. Estimates vary on the prevalence, going down to the Women's Health Study, all the way up to phone surveys that show almost 50% of patients. And for patients coming in for cataract surgery, there are certainly a lot of studies that have been done, but most studies show at least 50% of patients coming in for cataract surgery have some form of dry eye. And there's an epidemic of dry eye that's out there. A lot of it has to do with diet. We don't consume enough omega-3s, too many omega-6s. I have to admit, I do like to go to McDonald's every now and then, but you have to eat a little more green, leafy vegetables. In addition to that, we don't blink a lot. People spend too much time looking at cell phones and computers, and they don't express their meibum as effectively. So there's an epidemic of dry eye going on right now with lipid aqueous and mucin, all three being effective. So what is a healthy tear film and ocular surface? Well, it provides maximum comfort. The epithelial cells are hydrated in osmotic balance. The epithelium is healthy. The tear film is robust, and the refracting surface of the eye is in good shape. When the tear film is compromised, the cells are dehydrated, out of balance, the surface of the cornea becomes irregular, vision fluctuates, and that happens to be my favorite symptom, by the way. Everyone should have a favorite symptom. My favorite symptom is fluctuating vision. Whenever I hear that, I'm thinking automatically that this is dry eye disease. So that brings us to how do artificial tears work? And there are different types of artificial tears. Some of them combine a lot of these different aspects. They can counteract hypertonicity, so a hypotonic tear can reverse the increased saline that's found in dry eyes. There are oil-containing tears that are very effective for patients who have meibomian gland disease, where the lipid component of the tear film is reduced. There are some tears that have increased viscosity. Usually with increased viscosity, there's a little more blurring, but these ingredients allow a more bioadhesive property to the tear and allow it to have increased contact time with the ocular surface. And then there are small non-ionic organic compounds that build osmotic strength without damaging proteins. So when a tear film is healthy, it has a constant osmolarity. Again, the tear osmolarity under 300 is ideal, but under 308 can be considered normal. In dry eye, the quantity of water of the tear film is decreased, and it doesn't really matter why the tear film is decreased. It can be increased evaporation or decreased production. The bottom line is the patient's not producing enough tears, which is why a tear secretagogue is a very nice therapy for improving ocular surface disease. Because there's less water, the concentration of sodium and potassium increases. That raises the osmolarity. That upsets the isotonic balance of the eye and damages the epithelial cells. Hypertonic tear film causes the cells to become dehydrated and out of balance and damages the cell membrane. So normal cells exposed to a hypertonic environment, there's water loss. You can either increase the water, which restores cell volume, or if you don't do that, the cells are going to crenate, they'll be irregular, and sometimes cell membranes will be damaged. In addition, when we think about dry eye, you have to think about not only the active ingredient, but the inactive ingredients as well. And in the old days, we used a lot of BAK, benzalkonium chloride, and this preservative has been shown to certainly disrupt the stability. So it was almost counterproductive to have a artificial tear that contained a preservative that further damaged the ocular surface. And today, most tears have much more comfortable preservatives. BAK damages epithelial cell integrity. There's a loss of goblet cells and a reduction in tear breakup time. Transient preservatives are much more effective. They're gentle, they're bactericidal, and some of the new bottles that are coming out now are multi-dose, preservative-free completely, which is obviously ideal. And here you see an epithelial cell model looking at different transient preservatives, showing how they maintain the ocular surface. And all the way to your right, you see benzalkonium chloride, where the cells have been dramatically damaged. Purite and other transient preservatives really do a good job of maintaining the ocular surface. There are basically three types of artificial tears. There's wetting agents, there's multiple action tear substitutes, and there are ocular surface modifiers. Wetting agents have limited residence time. They basically lubricate the eye, but they don't stay in place for a long time. Multiple action tear substitutes improve the quality and quantity of the tear film. They stay for a long period of time. They've really become the linchpin for what we use. And I think of like the sustained group of tears as being a beautiful tear that contains multiple different molecules that maintain adhesion to the ocular surface and provide long-term contact without blurring the vision. Tears are composed of different ingredients. You have viscosity enhancing agents like hyaluronic acid, HP guar, certainly very good. That increases the retention of artificial tears on the ocular surface. You have electrolytes that are healthy. Usually they're hypotonic. You have osmoprotectants. So um, there are certain ingredients such as trehalose that will allow the cell membrane to become dehydrated without the cell membrane being damaged. And then there's oil replacement again, which is very effective for patients who have meibomian gland disease where they don't have the normal oils. And these patients do very well. And the oils are usually mineral oils or castor oil. Polymers and artificial tears include cellulose esters, vinyl derivatives, and viscoelastic agents. All play a significant role in dry eye. Hyaluronic acid is probably the one that's best known and certainly the most common tear that's used in Europe. Sodium hyaluronate retains water 1,000 times its weight, and it allows for a nice shear rate. This is the same ingredient found in viscoelastics that you place in the eye during surgery, and it allows the tear film to have a reduced shear rate so that when the lid moves over the ocular surface, there's no damage to the cornea because of the viscosity agent. Hyaluronic also enhances corneal epithelial cells and allows for epithelial regeneration. Osmoprotection is an interesting new area, and there are several different osmoprotectants. I won't go into all of them. Erythritol, taurine, ectoine, L-carnitine all play a role. Trehalose, again, I mentioned, and trehalose is a very interesting story. They block oxidative stress, they reduce cytokines and MMP9s, and allow the cornea to survive a oxidative stress that normally it would not allow. So the cell membranes remain intact, where in a normal environment they would not. I'll go past this. Trehalose is a bioprotective. It's a new ingredient found in several tears as well. And the story behind trehalose is really pretty interesting in that it improves ocular surface recovery under hypertonic environments. And it was in 1702 that Anton van Leeuwenhoek, using a microscope, discovered that there were certain insects that you could actually revive. These were completely dry, apparently dead insects called sea monkeys that were completely dried, and that you could add water to them and actually resuscitate them. And later it was found that these organisms had high amounts of trehalose that allowed the cell membranes to become completely dehydrated, and that allows them to be replenished later on without damaging the cell membrane. Vitamins are also found in some tears. Vitamin B5 is found to be water soluble and accelerates corneal epithelial regeneration. And then let's get to the lipid-containing drops, which I think has probably been the biggest innovation in tears over the last couple of years, and that is the addition of lipid to these tears. It's been recommended that these are effective in managing meibomian gland disease. And that is certainly the single most common cause of dry eye. Based on Michael Lemp's seminal work, we know that about 86% of dry eye has either primary meibomian gland disease or has mixed dry eye disease. So having a tear that has a lipid component, I think, is very effective for these patients. And the clinical goal is to replenish the lipid layer. These can be done with castor oil, triglycerides. They are available as emulsions. They form emulsions on the surface, and they hold the oil in place. And HP guar borate is probably the best known. That homogenizes and reduces droplet size and allows the tear film to be stable on the ocular surface, providing a resuscitation to the lipid layer. Lipid-containing tears, gels, and sprays reduce inflammatory cytokines, lubricate the lid margins. They're bipolar lipids. They improve symptoms and tear film evaporation rates, and they improve tear breakup time and meibomian gland expressibility. There are several different lipids available. Medium chain triglycerides are components of a glycerol background with 3 fatty acids, and they allow the tear to be stabilized so that you don't have to apply the drops nearly as much. The drops can be applied 4 times a day instead of every hour because the lipid layer is replenished, allowing the tear film to become more stable. It's a lot of us prescribe tears as a PRN medication. However, it's been shown that the optimal use of tears is really to have the patient use them specifically 4 times a day or more, so that the patient has a continued tear film supplementation, so that the tear film is stabilized, and that this actually stabilizes and improves the ocular surface very effectively. In summary, there are different ingredients that are used in artificial tears. There are wetting agents that improve tear film instability. They are used for patients who have increased evaporation, aqueous deficiency, or decreased wettability. These include oily agents, viscosity enhancing agents, and viscosity enhancing electrolytes. There are multiple action tear films, which I think is ideal. These are tear film supplements that will treat hyperosmolarity and also improve the lipid layer of the tear film. They may contain osmoprotectives as well. And then there are ocular surface modulators that reduce inflammation. Also, in talking about tears, I want to just briefly mention serum tears. This is my ace in the hole. When I have patients who have tried everything, I find serum tears to be a wonderful supplement to conventional tears. And serum tears were first described in 1984. And we basically take a patient's own blood, spin it down, and throw away the erythrocytes, leaving just the serum behind. And these have so many different proteins, fibronectin, laminin, growth factors that support the ocular surface. So where an artificial tear might just contain a few electrolytes, maybe some lipid, these actually contain the proteins and the anti-cytokines that improve the ocular surface. And we use these very commonly for severe dry eye, persistent epithelial defect, neurotrophic keratitis, inflammatory conjunctivitis. And this is kind of my forerunner to going to oxybate for neurotrophic keratitis. I find that to be certainly the best therapy we have for significant neurotrophic disease, but serum tears can sometimes provide a interim therapy for some of these more moderate treatments. And that brings us to neuromodulation. Neuromodulation is becoming increasingly important, and we're realizing for the first time that neuromodulators play a very significant role in dry eye. We used to think that dry eye was an aging disease. Well, now we know that it's an inflammatory disease, and it's also a neurosensory disease. And it's estimated that 20 to 30% of patients who have dry eye actually have neurosensory limitations. The first therapy that I'm aware of for treating the neuro component of dry eye was True Tears. That was a neurostimulator where this was actually these probes were placed in the patient's nose, creating an electric pulse that stimulated tear production. And you can actually see the tears improving while you evaluated the patients. Following this electrical stimulant, varenicline has been approved by the FDA and is currently used now, which is a drug that's inhaled, and it's believed to activate the trigeminal parasympathetic nicotinic receptors in the nose, signaling the body to produce more natural tears. The exact mechanism is unknown, but it doesn't just cause reflex tear production, it actually increases the quality of the tears as well, which is absolutely wonderful. It increases the mucin and the lipid layer as well, and it promotes natural tear production. The trigeminal nerve is accessible through the nasal cavity and can be activated by stimulating nicotinic acetylcholine receptors. This has been approved for the past 4 years and is recommended that one spray in each nostril be performed twice a day. And here you can see how there was a dramatic increase in tear production in patients on varenicline spray, with about half the patients getting a 10 millimeter increase in Schirmer scores, which is a pretty remarkable result. The limiting aspect of varenicline has been that some patients don't find it comfortable and there can be sneezing associated with it, but the onset is very rapid, and it does produce tears very, very comfortably. Now, Walter mentioned this before, but I think it's worth repeating that the lacrimal function unit is important, and um, it's kind of a um, cyclic pathway where corneal sensation allows afferent nerves to go to the trigeminal nerve in the brainstem that then causes an efferent nerve to go to the lacrimal gland, the meibomian glands as well, to produce more tears. And this feedback loop has been very, very well studied, and it's something that we're all familiar with. Now, we all know about cool sensing receptors and polymodal receptors. This is something that's been around for a long time. You know that if you cut an onion, you're going to get a polymodal receptor that's going to cause irritation, that's going to cause reflex tearing. You know that if you go out on a very cold, windy day, your eyes feel cold, and this cool sensing receptor produces more tears as well. Just as a foreign body in the eye is going to produce tears as well. These are well accepted sensory changes. However, the real landmark moment was the knowledge that there were other cool sensing receptors that were not clinically uh, relevant. You could not actually tell that the temperature had changed. And Walter mentioned this before, but there was work done by two scientists out of California, one out of Los Angeles, one out of San Francisco, Julius and Palapudian, and they actually won the Nobel Prize for this research in 2021. And the Nobel Prize was to show that our body regulates itself with these sensors, TRPM8, transit receptor potentials, that will measure changes in our environment that our body can't physiologically notice. So we don't notice that our eyes get a little cooler between blinks, but these cool sensing receptors can locate as little as 0.1 degree centigrade change in the tear film temperature. That revelation allowed our understanding of a new pathway that has really opened up research now that has resulted in new treatments that allow us to take advantage of these cool sensing receptors so that we can actually treat dry eye in a very novel and new way. And this is called the basal tear response. So these are small reductions in temperature associated with interblink evaporation versus the polymodal receptors, which are more physical, and mechanical receptors, which are reflex tears. And again, here you see the cool sensing receptors, which will locate even the smallest amount of temperature change versus polymodal or mechanical receptors that notice pain and irritation, which we're all familiar with. This led to the COMET 2 and COMET 3 studies, which were performed by Alcon for the improvement of Cultraman. The trade name is Tripteer. And these are patients who had dry eye, and they were looking for the primary endpoint of how many patients had a 10 millimeter increase from baseline in unanesthetized Schirmer scores on day 14. They looked at Sandy scores or symptomatology scores, and the change in unanesthetized tear film. And here's kind of the take-home message. This is the beautiful slide. And it shows that more patients achieved a significant increase in natural tear production with accoutrement or triptyr. And this shows that in one study, Comet 2, 42%, and in Comet 3, 53% of patients had a 10 millimeter increase from baseline of unestheticized Schirmer scores on day 14. This is pretty remarkable information. So up to 4 times more patients achieved a 10 millimeter increase. And for me, 10 millimeters of tear production is normal tear production. When you have an increase in 10, it means the patient essentially has a normal tear production. This is the proportion of patients achieving a greater or equal to 10 millimeter increase from baseline in unesthetized Schirmer tests on day 1 and day 30, showing that these patients get an increase in tear production right away, right on day 1, right on the first dosing, and it continues for a full 3 months. So that the drug used twice a day allows consistent results, which were observed at all time points during the trials. Post hoc exploratory endpoints showed that patients who achieved greater than 10 millimeter unestheticized Schirmer scores was extremely high in Comet 2 and Comet 3. You can see here on day 90, 71% of patients had a Schirmer score greater or equal to 10 in Comet 2 and 83% in Comet 3. So an enormous number of patients had essentially normal tear production with the use of accoutrement or triptyr. In addition to the patients actually having more tear production, there was also improvement in corneal staining, but most importantly, there was an improvement in Sandy scores, which are the patient's perception of whether they felt better or not. And here you can see the key symptom results in Comet 2 and Comet 3. Comet 2 was clinically significant. Comet 3 showed a strong trend towards significance, showing that triptyr reduced symptoms as on day 28. And again, that makes the patient feel better. As an eye care professional, it makes me feel better when I see the cornea looks better. So this is corneal and total conjunctival staining, showing that as early as day 7, but certainly showing increasing trend towards day 90. There was an improvement in both corneal staining and conjunctival staining with the use of triptyr. In conclusion, dry eye has been underdiagnosed and undertreated by all eye care professionals, optometry and ophthalmology. It significantly affects cataract and refractive surgery results. Dry eye disease results in significant morbidity for our patients, which results in decreased vision, reduced quality of life. These patients are often depressed. They have a chronic illness that affects them on a daily basis for decades. And recent improvements of neuromodulation and artificial tears, as well as treatments now in clinical trials, will significantly enhance our ability to manage dry eye disease in the future. And I think it's a very exciting time to be involved in dry eye. You think back just 25 years ago, there was no therapy for dry eye at all. And now we have a variety of therapies that are available to us to help make these underserved patients feel much better. So now that we've gone through this trial, let's go to our post-test clinical vignette. Again, same case, 72-year-old male, refraction of plus 150 with some cylinder, wants cataract surgery, has a pertinent history of Hashimoto's thyroiditis. We know it's an inflammatory dry eye as well. Would like to be spectacle independent. He's been treated for dry eye with tears, but continues to complain of fluctuating vision. He's light sensitive. His osmolarity is high. His MMP9, which is an inflammatory marker, shows that there's an inflammatory dry eye. His breakup time is 4 seconds, which is low. Schirmer's are also low. The tear lake is diminished, and the conjunctiva and cornea both have staining. Most importantly, the cornea is stained centrally. His meibomian glands are 2+ inspissated, and he has minimal blepharitis. With that as a background, let's take our test. Would you consider all the following except for topical lifidographs, topical lotiredinol, change to a different artificial tear, topical perfluorooctane, or topical lotilaner? So what would you consider here in your therapy for this patient? Knowing again that he has an inflammatory dry eye, and he has meibomian gland disease and probably aqueous deficiency dry eye as well. The fact that the Schirmers are low and the meibomian glands are abnormal probably means he has both. So what would we do here? I think that you consider all the following except for, and the biggest result was change to a different artificial tear. And I think that that's probably not the right answer. I think, well, let me reword. I think that is the right answer. That when someone comes in, they have significant dry eye and they're already on an artificial tear, I'll consider changing the artificial tear, but I almost always will start another therapy as well. For these patients who have inflammatory dry eye, I think a cyclosporin or a lifitegrast is a very good therapy to consider. I like to produce more tears as well. I've been very happy with Acultramin or Tripteer in these patients producing a lot more tears. So that's been a very nice therapy as well. Topical lodulator, I kind of saved that for patients who have significant collarettes. So there weren't any collarettes here. So I would consider that a correct answer as well. I don't know if I would go to lodulator on this patient who doesn't have any sign of collarettes. So I think changing tears would have been a good answer as well as topical lodulator. Good. All right. So let's move on. We've basically just gone through dry eye. We've talked a little bit about neuromodulation. We've talked about different tiers. Let's go to really do a deep dive on neurosensory dry eye and ocular surface disease. And here's our fourth case. And this is a 56-year-old female, poor vision for 3 months following hyperopic LASIK. So first of all, I don't do LASIK very commonly on 56-year-olds who are hyperopic. The patient was originally a +250 and a +275. And now the patient's a +0.5 in the left eye. And the vision only goes to 20/50. So not only does the patient not have a refractive result, but they're not seeing well. The examination reveals Schirmer scores of 14 in the right eye, but her left examination reveals 2+ interpalpebral fluorescing staining. She's got a poor Bell's phenomenon. Her eye doesn't rotate upward. Her sensation is normal in the right eye, but it's absent in the left eye. I'm already getting a little worried. You've lost sensation in only one eye. Something's going on. Midway through the examination, the patient says to me, 5 years ago, I had an acoustic neuroma surgery. Could that be important? And obviously, that's what the problem here is. The patient had their facial nerve cut at that place and has lost corneal sensation. So we started the patient on an ointment at night. We started them on perfluorohexyloctane, a lubricant with minimal improvement. She has a cryopreserved amniotic membrane placed, and I like using amniotic membranes in these patients. I think that's the next line therapy. You could also consider serum tears. With 50% improvement, the patient got a little better. What's the next therapy that you would add to this patient? So they have a neurosensory dry eye, neurotrophic keratitis. They've been on lubrication, and they've used ointment and perfluorohexyloctane. What would you do next for this patient? Would you use lifitegrast, cyclosporin, loteprednol, oxervate, or oral doxycycline? Let's vote on what you would do next for this patient. Terrific. Okay. So let's go on to our next talk. Overview of the diagnosis, current and emerging treatments for the early and late stage neurotrophic keratitis. Again, my name is Eric Donnenfeld, and I'm a consultant to several companies that are in this space. So neurotrophic keratitis, we didn't really know a lot about neurokeratitis until relatively recently, and the Mackey classification has really given us a good way of defining this corneal degenerative disease, characterized by reduction or absence of corneal sensation. Stage 1 is just SPK, punctate epithelial keratitis. Stage 2, there's a persistent epithelial defect, and stage 3 is actually corneal ulceration. But neurotrophic keratitis is progressive and can present at really any stage, and early diagnosis is essential. And we've talked a lot about diagnosing meibomian gland disease, but I think it's really important to diagnose neurotrophic disease as well. And checking corneal sensation is just so simple, is to take a little Q-tip, make a whirl at the end, and just touch the patient's cornea and see how they respond. Again, the Mackey classification starts out with just epithelial disease with punctate erosion. Stage 2, you get a larger erosion. In stage 3, you actually get into the stroma with loss of stroma, which actually will end up in corneal scarring and loss of visual acuity very commonly, permanently. And here you see some nice clinical photos of neurotrophic keratitis showing the PEK, the percent of the defect, and then finally the corneal ulceration. If untreated, moderate neurotrophic keratitis progresses to severe disease, which is associated with a severe and profound loss of vision, which is why it's really important to treat neurotrophic keratitis early, treat it aggressively, and try to resolve it as efficiently as possible. There are a lot of different reasons for neurotrophic keratitis. Chronic dry eye is actually probably the most common one. We see neurotrophic keratitis in a lot of dry eye patients, but surgery involving the eye or brain, herpes infections or neurotrophic disease, diabetes and multiple sclerosis, a lot of topical medications and long-term contact lenses can all cause neurotrophic keratitis. So the ocular causes of neurotrophic keratitis are infections such as herpes, post-LASIK, you can see it occasionally, contact lens wear. The systemic effect is most commonly due to diabetes, and patients who have brittle diabetes almost always have neurotrophic corneas, which is why they sometimes do poorly after cataract surgery, not because of the cataract surgery itself, but because of the medications we place them on, most notably non-steroidal anti-inflammatories, which have been shown to be associated with corneal melts, particularly in patients with neurotrophic disease. CNS causes of neurotrophic keratitis include neurosurgical procedures such as a facial nerve cutting and an acoustic neuroma, stroke, neoplasms, etc. And finally, there are some genetic diseases that are fairly rare, usually seen in infancy. Most notably, it's Riley-Day or familial dysautonomia. Patients present in many ways. Neurotrophic keratitis may be asymptomatic because they have a loss of corneal sensation. So sometimes you'll have the loss of sensation and you'll have breakdown of the cornea. The corneas will look terribly and the patient won't really feel very much. So you can't rely upon pain in these patients. There's a lack of conjunctival injection. There can be non-healing epithelial defects, and it can even be corneal edema. It's important to take a history in these patients. I look for diabetes, I look for surgery, particularly ocular surgery, and do corneal sensation. Corneal sensation I have found to be so helpful in managing these patients. You know, we have a quantitative treatment of Cochet-Bonnet aesthesiometry, and there's some new treatments as well. But just taking a cotton swab or a dental floss and touching the cornea can really give you very, very useful information. Like you come in from the side so the patient can't see it. These patients can very commonly have secondary infections, and that's one of the things you worry about with neurotrophic keratitis is that they may actually develop infections because of the loss of the barrier function of the epithelium, and you should examine them for systemic immune disorders. Here's an example. Now, this example, I actually come in from the side. I don't come in straight ahead. I come in from the side more so the patient can't see the Q-tip coming to them. And I take a cotton swab and just wisp it out, or you can take a dental floss and just touch the cornea very gently and develop a scoring system of maybe 0 to 10 and say to the patient, how do you feel on a score of 0 to 10 in this eye? And then compare it to the other eye. And then there's the Cochet-Bonnet aesthesiometry, which is basically a fishing line of various lengths, and the patient feels it, and they can give you a report of when and where they can feel their eye being touched. The tear film and Ocular Society of the International Dry Eye Workshop stated in 1995 that dry eye is a disorder of the tear film. And they have now added in 2017 and in the newest rendition in 2025, they say that dry is a multifactorial disease, and they've added a neurosensory abnormality because we've come to the realization that corneal sensation plays a very, very dramatic role in dry eye, as well as other neurotrophic abnormalities. In dry eye, there's a reduced tear secretion, which leads to inflammation and peripheral nerve damage. The high density and the superficial location of the sensory nerve between the epithelial cells and the surface make them particularly vulnerable to injury. And this was a landmark study in clinical ophthalmology that showed the prevalence of corneal sensitivity loss in patients with and without dry eye. And they found that 30% of patients with dry eye have a neurotrophic keratitis. And that explains why a lot of patients who have dry eye won't be symptomatic. They'll complain of visual changes like fluctuating vision. Also explains why sometimes when their dry eye gets better, their ocular surface will become more uncomfortable. Just as like when you fall asleep on your leg and you get pins and needles and you get that pain, that's what happens to your cornea as well. When the corneal sensation returns, patients who have improved ocular surface will sometimes be more symptomatic and a little bit more painful, but they're actually feeling the discomfort because their sensation has returned. Treatment of neurotrophic keratitis, according to the American Academy of Ophthalmology, involves a therapeutic approach. The aim of the therapy is to promote persistent epithelial defect healing and prevent the development of corneal ulcer. And the focus is on corneal ulcer healing and prevention of corneal perforation in stage 3. So for stage 1, what does the American Academy of Ophthalmology recommend? They recommend lubricants, so tears. I think that's a great start. These patients, I would always recommend transiently preservative or preferably non-preserved unit dose tears. Punctal occlusion goes a long way. I've become a big fan of lacrophyll, which is a cross-linked hyaluronic acid that fills the punctum and actually provides a better occlusion. Serum tears I talked about previously as being a very effective therapy. Bandage contact lens, human nerve growth factor drops, oxybate, and cryopreserved amniotic membranes. So the Academy recommends cryopreserved. Not all amniotic membranes are the same, and I think cryopreserved is the best. I happen to like one called CAM 360. They come in different ways. There are amniotic membranes that have rings around them, and I find them a little uncomfortable for some patients, but I like to use a cryopreserved amniotic membrane. I'll cover it up with a contact lens or a collagen shield. For stage 2, again, we use lubricants, punctal occlusion, serum tears, bandage contact lenses, and we go to human nerve growth factor drops, cryopreserved amniotic membranes, and tarsorrhaphy. And then finally, when you get to stage 3, when you actually have corneal ulceration, we use all these things. I find that oxybate is extraordinarily helpful for these patients, but I'll also will be very quick to do a tarsorrhaphy. N-acetylcysteine, methylprogesterone plays a role. I like oral tetracycline too. I use oral doxycycline. I'll use 50 milligrams twice a day for a week, and then 50 milligrams once a day for months on end. And I use that for stage 2 and for stage 3, in that the doxycycline has an antibiotic effect, but it also has an anti-collagenylytic effect, which actually prevents corneal ulceration and reduces inflammation. Serum tears we mentioned earlier. I find these very helpful. They have growth factors that allow the epithelium to be modulated, and it's indicated for severe dry eye, but I like to use it even some moderate dry eyes, persistent epithelial defects, neurotrophic keratitis, and for very bad inflammatory conjunctivitis such as Stevens-Johnson or graft versus host disease. Serum tears are taken from the patient's own blood, but in FDA trials now are some serum tears that are being developed that are that look very effective, that don't have to rely upon patients having their own blood drawn. This was, I think, again, another landmark paper that I think is really important from ophthalmology. And this is a study that looked at cryopreserved amniotic membranes in dry eye disease. And again, all amniotic membranes are not the same, but they actually showed a regeneration of corneal nerves using cryopreserved amniotic membranes. And these nerves are responsible for regulating corneal sensation, the blink reflex, and epithelial regeneration. And this prevents the self-perpetuating cycle of deterioration you see in a neurotrophic cornea. So amniotic membranes have been shown not only to improve the ocular surface, but improve the neural architecture of the eye as well. And I think this is an important study to consider, which is why I almost always try an amniotic membrane, again, a cryopreserved amniotic membrane. The nice thing about these amniotic membranes is they can be left at room temperature, and they are very well managed. Here's the 2017 study that looked at 20 patients who were on maximum medical therapy, and one group got amniotic membranes. And here you can see the corneal nerve density dramatically increasing at 1 month and at 3 months, as well as an improvement in corneal sensation. So the conclusion is that cryopreserved amniotic membranes, and again, I'd be using the CAM 360, is also rich in neurotrophic factors that may promote corneal nerve regeneration, which is why it has a long-lasting effect on dry eye disease. And persistent epithelial defect is that it works acutely and it has a chronic effect at improving nerve regeneration. And that brings us to nerve growth factor. This has been one of the biggest improvements in, ocular surface disease that I have seen in my lifetime, nerve growth factor. Endogenous nerve growth factor is essential to corneal homeostasis. Nerve growth factor is a protein that allows us to maintain our neurons. It's believed that corneal integrity is improved through corneal innervation, tear secretion, and epithelial cell growth. German is the active ingredient in this product. It's structurally identical to nerve growth factor that's produced by the body. So we have a biomimetic. It's exactly the same as what our natural body produces. And these are the pivotal studies that were performed in Europe as well as in the United States that looked at oxybate in the management of neurotrophic keratitis. In Europe, there were 3 treatment arms. In the United States, 2 treatment arms. And the course of therapy was identical, 8 weeks. Follow-up was 48 weeks in Europe and 24 weeks in the United States. And the endpoints were complete corneal healing at week 8 in Europe, as well as in the United States. And the trials included a diverse pool of patients who had neurotrophic keratitis. The majority of them were stage 2 and stage 3, with patients having a few more stage 2 in the United States than in Europe. And there was a diverse pool. Neurotrophic keratitis can be due to a lot of different diseases. So the cause varied greatly. They include things like herpetic eye disease, neurosurgery, dry eye, among other causes of dry eye. And here you see just a beautiful visual representation of how growth factor improved corneal healing, both in Europe and in the United States, showing that at baseline, they have these defects for weeks on end, resolving as soon as 4 weeks, often, but certainly by 8 weeks, showing complete resolution of the defect with improved tear luster as well. And up to 72% of patients achieved complete healing at 8 weeks. These are patients who had gone months and sometimes several months with corneal breakdown, many times with stage 3 macular disease with corneal ulceration. And these patients were receiving an 8-week course of German, and they received the drop 6 times a day. Most patients remain completely healed for almost a year after therapy, after 1 8-week cycle. So that's one of the concerns that we had with this drug, was whether you stop the drug, would the disease go right back? And the answer is no. Most of these patients achieved healing and then stayed healed after their therapy. Nerve growth factor was well tolerated in the clinical trials. The most common adverse events were eye pain, which you sometimes see again because when you have an improvement in corneal nerves, the sensation improves. This was reported in approximately 16% of patients. But other than that, just some mild hyperemia and inflammation was sometimes seen. In clinical trials with nerve growth factor, there was no evidence of systemic absorption or immunogenicity. And that brings us to a new therapy that we talked about previously, as did Walter, and that is a way of treating dry eye with a new therapy. And this is a cultramin or a triptyr, and it basically regulates the lacrimal functional unit. Again, we have cool sensing receptors that will sense up to 0.1 degrees centigrade of tear change. And that's versus the normal sensation that you and I are all very familiar with, polymodal receptors and mechanical receptors. If you get a lash in your eye, you'll tear. If you cut an onion, you'll get tearing. Those are things that you have direct sensation that makes you feel uncomfortable. The difference is that in cool sensing receptors, you don't know that the temperatures can't change. You don't know that your baseline has been altered. And that's the wonderful aspect of this new drug, is that it actually evaluates a pathway that we had not been familiar with until just a few years ago. And these small reductions in temperature associated with interblink evaporation produces basal tears. And again, I showed this slide earlier. This is basal versus reflex tears. Julian and Polypudian discovered this, and they won the Nobel Prize in 2021. And now Alcon has harnessed this pathway to use a drug to improve basal tear production by looking at the cool receptors. The FDA trials, which led to the approval and now the actual clinical availability of triptyr or cultramin, was an increase in Schirmer scores of greater or equal to 10 millimeters of Schirmer scoring with unanesthetized corneas, looking at Sandy scores and other secondary endpoints as well. I went through this before, but I think it's worth repeating that the beauty of accoutrement is that these patients many times have normal tears now. People have dry eye for years on end. Now we're producing more than 10 millimeters of tear production. This slide shows an increase of tear production of 10 millimeters, but this shows the proportion of patients achieving greater than 10 millimeters at baseline versus day 1 and 90, showing that you get almost an immediate effect with the cultramin triptyr, with patients showing approximately 50% of patients achieving a 10 millimeter Schirmer score increase on day 90. And this is the proportion of patients who achieve more than 10 millimeters of unanesthetized Schirmer scores. So 70 to 80% of patients had Schirmer scores greater than 10 in this trial versus a baseline of about 6. So almost a doubling of the tear film in these patients. The Sandy scores increased got better in both trials. Actually, the numbers reduced, which is reflective of improved symptomatology. This was clinically significant in Comet 2 and showed a strong trend in Comet 3. So patients feel better, and as a ophthalmologist or as an optometrist, I feel better as well. I look at these patients and their corneal sensation improves, their corneal staining reduces, and their conjunctival staining gets better as well. So with an improvement in corneal staining and conjunctival staining, you have an improved ocular surface, resulting in patients feeling better and probably seeing better as well. I'll just mention there's some other drugs that are in trial now to improve damaged collagen, which will maybe be available in the future. This is from Stewart Therapeutics. It looks at healing irregular corneas, and this may play a role in the near future, showing an improvement in corneal staining by basically improving the corneal metabolism. So we have developed some beautiful new drugs that make neurotrophic keratitis better. I like to start with lubricants. I use ointment at night. I think a cryopreserved amniotic membrane is an extraordinarily effective therapy for neurotrophic disease, but for patients with stage 2 or stage 3 or long-term stage 1, there's nothing better than using oxybate, which is nerve growth factor, and I think this is a wonderful drug. For patients who need maintenance, sometimes I'll use an amniotic membrane and I'll use oxybate and I'll maintain them on serum tears for long periods of time, and this can actually help stabilize the tear film. Sometimes they need a second course of oxybate, and then we have some new drugs that are in our pipeline now that are moving forward very quickly that I think are going to be very, very effective in managing ocular surface disease, especially in patients with neurotrophic keratitis. The eye-opening research that for me I think is really worth repeating is some of these new studies that have shown that patients with routine dry eye, that 30% of them actually have a neurotrophic component to their dry eye. So neurotrophic keratitis is extremely common. Managing it can be very effective and rewarding. And if you're not doing this routinely, for patients who have significant dry eye, any type of persistent epithelial defect at all, certainly look at corneal sensation. I think corneal sensation is underutilized and very helpful in the diagnosis of these very common diseases. So with that, let's go to our post-test clinical vignette number 4. And we'll go back to this case. This again is a 56-year-old female. She had hyperopic LASIK and was sent to me actually for a topographic laser. She was originally a hyperope, and now she's still a little hyperopic in the left eye. But the important finding here is that even with the best prescription, the patient only saw 20/50. And the reason the patient saw 20/50 was that the patient had corneal fluorescein staining in the interpalpebral fissure in the left eye and not in the right eye. The patient's Schirmer scores were also a normal 14 on the right and an abnormal 3 in the left eye. Midway through the examination, the patient actually said to me, you know, I had an acoustic neuroma surgery 5 years ago. You think that could be possibly why I'm having this problem? We put the patient on an ointment at night. Great. We used perfluorohexyloctane with minimal improvement. She got a cryopreserved CAM 360 amniotic membrane with a 50% improvement, which is what I would expect. They certainly did much better. And what would you do as your next therapy here? What would be the next thing that you would consider adding to the therapy that the patient has already received? And you have 5 choices. You could add lifitegrast, you could add cyclosporin, loteprednol, oxervate, or oral doxycycline. Let's vote and let's compare our results today from our pretest and see what we found. Okay, here we go. Our results show that the majority of you would use oxybate, and I think that would be exactly what I would use in this case. I would use oxybate as a very good treatment for a neurotrophic keratitis. This patient has a complete loss of corneal sensation. Yes, immunomodulators like lifitegrast or cyclosporin could be added here, but this is not an inflammatory dry eye so much as this is a neurotrophic dry eye. Oral doxycycline, all these drugs would be reasonable, but for me, amniotic membrane, oxybate would be my next line therapy. I'd do this, and I might consider putting this patient on serum tears for the long term going forward. Terrific. Okay. Well, let's go to our next speaker now. This concludes neurotrophic keratitis and dry eye. And Dr. Lee will give our pretest clinical vignette. I'm going to stop sharing the screen right now.
Thank you for the introduction. My name's Nan Lee. I'm one of the cornea providers at UT Southwestern Medical Center, and I'm an assistant professor there. So we'll go straight into our pretest clinical vignette. We have a 62-year-old biomedical engineer who is interested in undergoing cataract surgery with implantation of a toric IOL. The patient wants to have the toric lens aligned using the most precise method. And so which method should be used during this case? Our choices include manual marking only, digital microscope marking overlay system, or a femtosecond capsule marking for toric alignment. It looks like the poll has ended, so I'll go ahead and proceed here, and we'll return to this by the end of the talk. So I'll be giving a talk on a review of cataracts, preoperative and intraoperative imaging, and innovations in cataract surgery, both current and on the horizon. I have no relevant financial disclosures for this talk. So we'll be covering a review of lens anatomy, the types of cataracts, preoperative, intraoperative imaging, and innovations. So first, with our review, the crystalline lens is a biconvex avascular structure composed of epithelial cells. And it's the structure with the most protein biomass in the human body. And the lens grows from neuroectoderm and surface ectoderm cells. And as it grows throughout life, secondary concentric fibers grow from the equatorial region, which is shown here in this photo. And this is affected by genetics and environment. And as the lens grows, the proteins break down via oxidation, UV exposure, and cellular damage. And eventually, we get the formation of a cataract. There are several different types of cataracts. We won't be covering an exhaustive list, but there are congenital cataracts, age-related, traumatic cataracts, and also cataracts that you get secondary to systemic diseases, ocular pathology, or different drug exposures. And we'll just do a quick rapid fire some of the types of cataracts here. This is a photo of a Morgagnian cataract. So what's happening here is that the cortex is completely liquefied and there's a dense mobile lens nucleus within this liquefied cortex. And it's really common to encounter zonulopathy in these types of cataracts. This here is a picture of a lamellar or zonular type of congenital cataract. And the characteristic appearance here is due to the opacification of one layer of the nucleus. This is a UBM showing an anterior capsule violation with lens material leaking into the anterior chamber. So this, of course, can lead to a profound inflammatory response and cause phacoantigenic glaucoma, necessitating a more urgent cataract extraction. Now, this is a classic photo of a Christmas tree cataract, and we all know this to be associated with myotonic dystrophy. But I think a forgotten about association is that hypoparathyroidism can also lead to the development of a Christmas tree cataract. So if you see this and the patient does not have myotonic dystrophy, it's important to do a systemic workup to look at calcium and parathyroid hormone. And last but not least, we have a cataract with Glaucomflecken, which is necrosed lens epithelial cells. So in patients who have pupillary block and acute angle closure glaucoma, this can lead to a necrosis of the lens cells. And also you can get iris atrophy. Also very common in these cases to expect zonulopathy. So moving on to evaluating for cataracts, of course, it's important to get preoperative imaging and measurements. However, the step prior to this is, of course, optimizing the ocular surface. And thankfully, we had many talks on how to do this today from our speakers. But of course, if the patient has dry eye, it's important to treat this and really optimize the surface before selecting a lens power. If the patient uses contact lens, it's important to do a contact lens holiday. And this varies whether they're on a soft contact lens or a hard or a scleral lens. If the patient has pterygium, it's important to consider removing the pterygium and allowing sufficient time for the Ks to stabilize before doing cataract surgery. And in patients with EBMD or Salzmann's, important to consider a superficial keratectomy, especially if there's irregular astigmatism in the central cornea. We'll be covering, doing a review on several types of preoperative imaging, including topography, aberrometry, biometry, and we'll briefly cover OCT and ultrasound, but we won't dive into this too deeply. So for corneal imaging, we have placido disc. So placido disc maps the cornea based on reflections using concentric rings. And this reflection is analyzed in order to measure the anterior curvature. So this does not give us any information about the posterior cornea. We have spectral sweep OCT, which is low coherence light that can create a 3D image. So this can give us information about the anterior and posterior cornea, gives us information about the thickness and the overall 3D structure of the cornea. We have Scheinflug, which uses a rotating camera to create 3D images. And Scheinflug can give us information about anterior and posterior cornea, which gives us an idea of the true corneal refractive power. It gives us thickness and elevation mapping, which is really important when thinking about things like ectasia and keratoconus. Wavefront analysis is used to map and understand higher order aberrations, and the wavefront can give us Zernike polynomial shapes, which describe aberrations such as spherical aberration, irregular astigmatism, or coma. And the newer systems, such as Pentacam, sort of combine all of these techniques and technologies to give us information about the cornea and higher order aberrations. And we can't talk about topography and tomography without thinking about ways to correct astigmatism during cataract surgery. And so just a couple guiding principles here. We know from prior studies that astigmatism with a magnitude of 3/4 diopters or more can definitely affect visual quality. We also know that eyes slowly, in general, become against the rule with age. And in knowing this, flipping a patient from having against the rule astigmatism to with the rule can be beneficial. It gives them a longer time of being glasses independent. And so I made a treatment algorithm or a flow chart here. And this is more of a starting point. It definitely does not cover all the complexity and nuance of correcting astigmatism at time of cataract surgery. But once I determine a patient has astigmatism on manifest and corneal imaging, my first question is, does this patient have regular corneal astigmatism? If the answer is no, then it's really important to find out what the etiology of the irregular astigmatism is. Now, like we said before, if they have dry eyes, well, the answer is straightforward. We need to optimize the surface before repeating measurements. If the patient has EBMD or Salzmann's, we need to consider doing a superficial keratectomy to correct this. If there's a scar or opacity that cannot be corrected, then likely they're not a good candidate for a toric lens. Now, with ectasia, it can be complex. In general, you might think that a patient with ectasia is not a good candidate for a toric lens. However, in my opinion, if the central 3 to 4 millimeter zone has regular astigmatism and the patient reliably improves with manifest, I think it can be reasonable to place a toric lens in these patients. They can be very happy. There's a major asterisk to this, however. It's important to ask the patient if they plan on going into a hard or scleral contact lens after surgery. And if that answer is yes, then I would not recommend a toric lens because if they're using a scleral lens to negate the corneal astigmatism, now well suddenly that toric IOL is inducing astigmatism at the lens plane. And the only way to correct that would be for the patient to wear glasses over their scleral. So in cases of a scleral lens, if the patient's going back in it, I do not use toric IOL. Now, if the patient does have regular astigmatism and it's with the rule astigmatism, if they have a diopter and a quarter or less, then I would consider a non-toric lens or corneal relaxing incisions. And of course, now we have access to T2 lenses, so you could throw in the use of a T2 lens in this scenario as well. Now, if the patient is with the rule that's over a diopter and a quarter, well, then a toric lens here that's T3 or higher could be very beneficial. And again, I do not flip patients that have with the rule to against the rule. Now, if the astigmatism is against the rule, I'm much more aggressive about correcting it. So if they have 3/4 of a diopter, or less, then you could consider a T2 or corneal relaxing incisions. No, if it's 3/4 or more, I would consider doing a T3. And again, I'm okay with flipping the patient to having with the rule astigmatism here. I want to do a brief review on higher order aberrations and sort of how I use this when thinking about lens selection in patients undergoing cataract surgery. So here's a display from the Pentacam. The upper left map is an axial curvature map. It gives us information about just the anterior corneal surface. The upper middle graph is the total corneal refractive power. This is derived from ray tracing. This gives us information about the anterior and posterior cornea. So this gives us an idea of the true refractive power of the cornea. And then there are several values there on the bottom right, and I'll highlight a few of those in the next slides here. Next, we have the holiday report, and this is one of the most important displays on the Pentacam when thinking about IOL calculations. The holiday report, also called the EKR 65, essentially the EKR is the equivalent K reading. And what Holiday did here was that he took the weighted mean of the 65% of the corneal power in a 4.5 millimeter zone. The reason why he chose a 4.5 millimeters is this is the average mesopic pupil size. And to kind of simplify it, the reason why Holiday did this was that we can use this in IOL calculations, and it can help reduce the risk of hyperopic surprise in even patients with post-refractive or irregular corneas. And when thinking about the K values here, such as the K1 or the K2, this isn't the true net corneal power. This display here isn't taking anterior and posterior corneal power. Rather, he's making an adjustment. So what Holiday did here was he looks at the posterior corneal powers deviation from average. So really, this K value is an adjusted value. Now, because it's an adjusted value, you can still use this in your second generation formulas, which have two variables, such as the Huygens. And then I'll move forward to just discussing some basics on higher order aberrations here. So a couple guiding principles. We know that the average corneal spherical aberration is around plus 0.27, and the young crystalline lens induces some negative spherical aberration to counter this. Also important to know that IOLs, of course, can be aberration inducing or aberration free. Most lenses induce negative spherical aberration, such as the Eyhance or the Alcon Clarion lens. Now, the SA60AT and the SN60AT are one of the few examples of lenses that induce some positive spherical aberration. So this can be helpful in your patient with history of hyperopic LASIK. Hyperopic LASIK induces negative aberration, so doing a positive IOL can negate some of that. And the Invista and the Acryos are thought to not induce any spherical aberration. So again, this is a Holiday report. There's a lot of values on here, but one of the most important ones that I think are relevant when thinking about premium lenses such as multifocals is the root mean square higher order aberrations. So this is sort of a measure of the total corneal irregular astigmatism. And ideally, this should be less than 0.6 in patients that are wanting multifocals. If the cornea is very irregular, this puts them at risk for aberrations, glare, halos. The next value that I look at is the total corneal higher order aberrations in the 4 millimeter zone. And again, ideally, we like this to be less than 0.3 in patients with multifocals. We know that high order aberrations greater than this, it's essentially equivalent to having a defocus of half a diopter. So this is very important when thinking about patients getting multifocals. Next, we'll move on to intraoperative imaging. So we have superimposable imaging overlay to help us with toric alignment. These are things like the Varian system or the Callisto system. And this has been shown to really help improve the risk of getting the eyewall aligned at the correct axis. We have intraoperative OCT. This is an image of an intumescent lens, and the OCT can show us that there is liquefied cortex that is causing some bowing of the anterior capsule. This is a case that we'd want to do a decompression for. Here's an image of the OCT capturing a hydrodelineation fluid wave. You can also use it to look at the wound construction and wound integrity. And here we're going to a more clinically or surgically relevant indication for OCT. In cases with posterior polar cataracts, you can use the OCT to inspect the posterior capsule. And in this case, it appears like the capsule is intact. This is a patient that had an intravitreal injection that caused iatric lens damage. And you can see here the OCT shows that there is likely already a posterior capsule defect. We also have intraoperative aberrometry with the aura. This can help us with IOL selection. This can help us with toric lens as well. And we have the 3D heads-up display thought to improve ergonomics during cataract surgery. So we'll talk about manual marking versus modern toric marking methods here. And some might wonder if these newer methods are superior to some of the more traditional methods. So there was a study from you and colleagues. It was a meta-analysis looking at 206 eyes across 4 randomized clinical trials. They found that both methods of manual marking and using a digital overlay was effective. However, the digital overlay had a statistically significant lower risk of postoperative IOL misalignment. There was a paper in the Journal of Cataract and Refractive Surgery in 2024 by Schultz. They looked at 28 eyes in their prospective study. And what they compared was digital marking versus femtosecond capsule marking. And they found that femtosecond capsule marking was much better, is much more precise, and it led to a statistically significant improvement in the misalignment rate. So when looking at digital marking versus femtosecond capsule marking, femtosecond was superior in this case. Moving on to thinking about aura, intraoperative aberrometry versus modern formulas. There was a study from Pentanelli and colleagues here. This was in 2025. And they did a large literature review. They looked at 61 studies. And they compared the aura to both standard and modern formulas. And they found that the aura was superior to the standard formulas such as the Hygas and SRKT. When comparing aura against modern formulas like the Barrett Universal and Hill RBF, they found that it led to similar refractive outcomes. Now, in post-refractive eyes, the aura was similar to the Barrett Truquet, but it actually outperformed the Hygas, the Shamus, and the Wayne-Koch-Maloney formulas. Now, this was a study in 2022 in the Journal of Refractive Surgery, and they looked at the outcomes when the aura disagreed with the Barrett and the Hill RBF. And they looked at 281 eyes, and these are eyes without prior refractive surgery. And they found that when the aura disagreed with the Barrett and the Hill RBF, choosing the lens that the aura selected, if that lens was a higher power, actually resulted in improved outcomes and also fewer hyperopic surprises. So this is a scenario where you might opt for using the aura if the aura disagrees with your Barrett and your Hill RBF. And Nicole Fram did a study in 2024 looking at over 1,000 eyes that underwent post PRK or LASIK, and they compared the results from the aura versus the Barrett Truquet. And actually, Nicole Fram and colleagues found that the aura outperformed the Barrett Truquet in eyes that have had myopic LASIK or myopic PRK. Next, we'll move on to talking about some of the current innovations. And there are so many nowadays, whether it's from intraocular lenses or phacoemulsification systems or ways to perform a capsulorhexis, but we'll just cover a few here. Of course, we have improved microscopes with optics and heads-up display. We have several advancements in intraocular lenses, and we'll cover some of those that have occurred in the last 5 years. We have more refined phacoemulsification systems and femtosecond systems. And we even have ways of doing cataract surgery without phacoemulsification, and this is called MyCore. With the 3D heads-up display, this employs a camera on a microscope that projects a 3D image onto a screen so that you can look up during cataract surgery, and this is thought to improve ergonomics. It can also be integrated with overlay systems, and this can also allow for team viewing and teaching. And there's a study published in the Nature journal that showed that when comparing the heads-up display to the traditional microscope, there was a significant improvement in the neck angle and a significant improvement in the surgeon's symptoms when using the heads-up display. Although, there can be, of course, a learning curve with using the heads-up display, a different angle for surgery and getting used to looking at a screen rather than looking through a microscope. We have several recent IOL innovations in the last 5 years. We have the IC8 Athera lens, and this is an FDA lens with an aperture. And the FDA approved this for patients that have up to 1.5 diopters of astigmatism. But not only that, this lens can provide some extended depth of focus. And this lens may also be useful in patients who've had history of RK and have irregular astigmatism because that aperture can block out some of the aberrations induced by the cornea. There was a study that compared the IC8 Athera lens with a monofocal control, and the Athera group had a statistically significant improvement in the intermediate and near vision with comparable distance vision. However, the patients that got the Athera lens did report a higher rate of visual phenomena, such as a sort of dimming effect that could be caused from the pinhole effect of the lens. And one very exciting innovation in the last few years has been the light adjustable lens. And I think this has been really revolutionary for patients who have post-refractive or irregular corneas, where our modern formulas may not be as good. So this comes in two forms. We have the LAL standard and the LAL plus. The LAL standard being just a monofocal, which you can adjust post-operatively. The LAL plus has some extended depth of focus. So this can be really helpful in patients who want a more full range of vision. You could implant the LAL plus bilaterally and do a sort of mini monovision to give the patients a more full range and keep them glasses independent. There have been some surgeons that have reported that patients have been unhappy with the distance quality with the LAL plus. So the other option, if patients are interested, is you could do the LAL standard in the dominant eye for distance, and then the LAL plus in the non-dominant eye to provide a range of vision. And of course, we have newer monofocal lenses, some that are marketed to have improved near vision, and some that are marketed to have reduced risk of aberrations. And I think the key point here is that we have so many tools now in our armamentarium to give to patients to better suit their lifestyles. We have newer phacoemulsification systems, one of the newest ones being the Alcon Unity. This was approved by the FDA in 2024. And this system, it can actually be used for anterior and posterior segment surgery, and it has a intelligent and thermal sentry that can detect the anterior chamber stability as well as the temperature to prevent wound burns. We have the B&L Stellaris, which is a Venturi system. This allows for improved followability. And also the Stellaris Elite, similar to the Unity, can be used in both anterior and posterior segment surgery. Now we have the J&J Veritas system, which uses peristaltic and Venturi, and it also has a customizable phaco tip. And then we have the Zeiss Quaterra, which uses a quattro pump technology, also to help improve AC stability. Now this is the Zeiss MyCore, and many of you have probably already heard of this, but if you haven't, this is a system that requires no foot pedal or phaco machine. It does not use ultrasound energy, so there is no heat generated. It just uses mechanical energy to emulsify cataracts. And it's all handheld, so there's no foot pedal, there's no machine setup. You can see here all that's required is sort of an IV pole with a BSS bag attached to an irrigation line. So it's a much more simple setup. Now, I think the downside really is the versatility and the learning curve. Since it's not ultrasound energy, you can't perform sculpting. So really the only way to disassemble the lens is to do primary chopping here. So that of course adds to the learning curve. That and of course using the throttle is also a part that kind of slows down the learning curve a bit. And some innovations on the horizon here. Of course, the accommodating IOL is something that I think a lot of surgeons have been waiting on, and there are several IOLs now that are in clinical trials that are possibly accommodating. We have optimization in artificial intelligence and lens formulas, and I think moving on forward in the future, these formulas will probably prove to be superior. And we have a robotic cataract surgery too, which is on the horizon. Now, there are four accommodating IOLs that are currently in clinical trials. And the first three lenses here, the Fluid Vision, the Juvene, and the Atia, sort of have a similar idea. These lenses have a structure that is either fluid-filled or silicone oil-filled, and bag compression can induce a sort of fluid-driven shape change to induce a sort of accommodation effect. The last lens here, the ACO lens, this is a different structure. This one's not designed for in-the-bag implantation. It's actually designed to be placed in the sulcus. And when the ciliary body muscle contracts, it sort of causes a lens accommodation to cause a myopic shift. So these are in clinical trials now. It'll be interesting to see the results of these clinical trials. And last but not least, very recently here, just October of this year, Horizon Surgical Systems completed the world's first robotic-assisted cataract surgery in a human eye. And if you follow Uday Devgan, or cataract coach, you'll see that he was a big role in this. He was a surgeon to do the 10 cases on this day. And so Horizon created this Polaris microsurgical robotic system that also employs artificial intelligence. And not only can this perform the surgery, but it combines digital imaging to provide a 3D image of the cataract and the capsule here. So you know exactly where the phaco tip is in relation to anterior and posterior capsule. It also employs machine learning to help with the surgical technique. And of course, the robot has no tremor, has vastly improved reaction time, and vastly improved precision. So this is something that is on the horizon. They've already had successful surgeries in human eyes. So I think this is closer than we think to being here. So just to summarize some of the key points, we have several advancements in imaging formulas and instruments that can allow us to have improved refractive outcomes. And of course, optimizing the surface, maximizing the quality of the imaging is crucial to getting good outcomes. We have intraoperative imaging and overlay systems that can enhance our surgical technique. And we have artificial intelligence, machine learning, and robotic surgery that is really at our front doorstep here. So it'll be interesting on how this affects how we perform cataract surgery, how it affects our workflow, and even how it affects resident and fellow training in the near future. Thank you all so much for your time. It was an honor to be here, and thanks for sharing your Saturday with us. We'll move on to doing the post-test clinical vignette. So again, we have a 62-year-old biomedical engineer who's interested in getting cataract surgery. He wants a toric IOL, but he's interested in having this IOL aligned using the most precise method. So which method should we use in this case? We have a manual marking only, we have a digital marking overlay system, or we have a femtosecond capsule marking for toric alignment. And most of you chose C, femtosecond capsule marking for toric alignment. So we have that study in the Journal of Cataract and Refractive Surgery that did show that femtosecond capsule marking was superior. So if the patient undergoes femtosecond and they're willing to have that done, using this can definitely improve our outcomes. That's not to say that manual marking and digital marking overlay systems don't have a place in aligning toric lenses. I still use digital marking. I still use manual marking as well as a backup in case my digital marking system doesn't work. And these still have great outcomes. But the studies have shown that femtosecond capsule marking can lead to some improved results. And so I'll pass it over to my friend and colleague, Keeshan Patel.
So I'm Kishan Patel. I guess I'll introduce myself a little more formally here in a few slides, but let's start with the pre-test case. A patient presents with a complication from cataract surgery and is aphakic. Which is the best technique for aphakia correction? Is it A, anterior chamber intraocular lens, scleral suture fixation of an intraocular lens, scleral sutureless fixation of intraocular lens, a non-surgical contact lens, or really it depends on the patient as each option has its pros and cons. All right, looks like the poll is closed, so we'll move on. So, I'm Kishan Patel. I have the honor of working at UT Southwestern here in the Dallas-Fort Worth area. I work with Dr. Lay, who's one of the anterior segment surgeons. I do mostly vitreoretinal surgery, but I also do complex anterior segment surgery, so anterior segment reconstruction. And then most of this talk is going to be about aphakia correction, which it can sometimes happen following cataract surgery. So I have no conflicts of interest to disclose, but I do want to say that most of the implants and materials I do talk about are not FDA approved. They're off-label. We are limited in the United States with what implants we have available. And so we'll talk more about that. So we'll briefly talk about eye anatomy. I think most of the people on this meeting are familiar with this, but we have the anterior segment, which is the front of the eye from the cornea up to the lens. And then we have the posterior segment, which is from the lens back to the retina, the optic nerve. And so the lens itself, the crystalline lens, Dr. Lay talked a little bit about the structure of the lens material. But if you look at the support structure, we have these zonular fibers are attached to the ciliary body, ciliary muscle off to the side. And so when we do cataract surgery, we really do rely on the natural support structure of the person to be able to hold our implants. So, when we do cataract surgery, we cut an opening in the anterior capsule that allows us to access these lens fragments, the nucleus, endonucleus, the cortex. And so then we clean that out with phacoemulsification generally, or with our anterior segment techniques. And then we have this nice thin shell left behind, this bag, and it's held in place with these zonular fibers. And so what we do is we just put a lens implant inside of that bag, and it just naturally holds that lens implant. We can adjust that a little bit during surgery to make sure the lens implant's nice and centered. But what happens when you have a hole in the back? So maybe, Dr. Lay talked about one of the cases where there was a posterior needle injury from intravitreal injection, or maybe they have a posterior polar cataract, and the posterior part of the bag is not super stable. And so the concern is if you put a lens inside of the bag, maybe it will fall to the back of the eye and not be stable enough. And so oftentimes what we do is we off-label put a different type of lens, usually a three-piece lens design, in the ciliary sulcus space. So we put it anterior to the capsular bag, held by that anterior bag and the remaining zonules, and that can give really, really good outcomes for patients. If there were lens fragments that fell to the back of the eye, that's where a vitreoretinal surgeon might come in and maybe do a surgery to take out these lens fragments from the back of the eye, but you can still use that support in the front to put a lens in the eye. What if the zonules are broken? Maybe the capsular bag is mostly intact, but there aren't great zonules. In that case, you can't really put a lens in the sulcus space in front of the bag because, it can slip out around the zonules. And so there is an FDA-approved lens that we can put into the front of the eye called an anterior chamber intraocular lens. And I'm not going to talk about it much in this talk, but it just sits on top of the iris. And there's only one manufacturer, I believe, in the US is making it, and there's some limitations in the sizes that you can get now. And they're falling more out of favor because really what we're trying to do nowadays is maybe put a lens in a more anatomic location. Maybe put it back where the bag should be. And this is what I'm going to talk about mostly, and that's potentially scleral fixating a lens. If you have no zonules at all, or if you have weak zonules, maybe you can still put an implant where the zonules in the bag would normally be. And so let's talk about a patient case initially, and I'll talk about a lot of different kind of lens fixation techniques in this talk. But we have a 63-year-old gentleman who came in with sudden unilateral painless vision loss after waking up. He did see an optometrist who said the retina and the nerve looked okay, but did see that the intraocular lens was dislocated in that eye. And so what do you ask the patient, right? You want to kind of know, okay, why did this lens dislocate? And so you ask about their ocular history, no really known ocular history other than having cataract surgery and having pseudophakia about 5 years ago. He hasn't really seen his PCP in a couple decades, but he's otherwise healthy as far as we know. But what do you have to ask in addition to that? Why would a lens dislocate? Did he have trauma in the past that can cause zonulopathy or zonular weakness? Has he had a vitrectomy that can also cause some weakness of the zonules? Does he have any predisposing ocular conditions like glaucoma, pseudoexfoliation, uveitis, which can cause weakness? Any connective tissue disorders? Is he a myope? Does he have a really long eye that can predispose you to having weakness in the capsular bag or zonules? And then you want to know, was the cataract surgery complicated? Was there anything that the initial surgeon saw that maybe would point to there being a complication down the road? And so I always try to obtain the operative note whenever I see these patients, and that will give me more of an insight into what's going on with their eye. And you want to pay attention to how the IOL is dislocated. Is the entire bag dislocated with the IOL? Is it just the IOL itself and the bag is actually intact? Maybe it just fell out through the posterior capsule and the anterior capsule and zonules are actually okay. You want to know what type of IOL the patient had. Ask them for their lens implant card. If they're very happy with their refractive state, you want to help achieve that. You want to use maybe the same IOL, the same power. You want to try to simulate what they were happy with before the IOL got dislocated. And then if you think about how ophthalmologists do surgery, we have the patient lying supine or lying flat on their back. And so I do that in clinic, right? I lay them kind of flat on their back to see what the IOL looks like, to see what I'm going to encounter during surgery. And that allows me to be a little more prepared. And then I look at their capsular support. I look to see if there's any vitreous that came from the back of the eye to the front of the eye. That allows me to better plan for a surgery. And then, of course, I examine the retina and make sure there aren't any additional interventions that I might need to take. And then, think about the visual prognosis. As a surgeon, we really like to have anatomic success. I like there to be a lens in the eye. I like the eye to look healthy when I take a look inside. But sometimes, if they're not going to have meaningful vision, sometimes you don't do surgery, or maybe you don't put in a new lens, and you don't kind of take the risk long term of doing something very invasive. And then you look at their anatomy overall. You look at their anterior segment pathology. If they have a lot of iris loss or they've had trauma, maybe you can't put in an anterior chamber intraocular lens, and you have to think of other ways of supporting a lens in the eye. And then I mentioned, you want to know what type of IOL implant they have in the eye. Because sometimes that can give you an idea of, oh, is this an IOL that you can reuse? Maybe I don't have to take that out and put a new one in. Or is this a really, really old lens that's made of polymethyl methacrylate, PMMA, which is almost like a piece of glass. And so if you're going to take that out, you have to make a very, very large incision. It's a much more major surgery. And then is the patient symptomatic? If the IOL is dislocated or if it's slightly sublux or shifted over and it's not causing any problems and the patient's happy, a lot of times I'll leave these patients alone, not do anything. And so when I was an early trainee, my approach to putting these lenses was really there's only three different ways. It's either in the bag, it's in the sulcus space, or you do an anterior chamber lens. And as as surgical advances have come about, and as I've kind of advanced my own training, I've learned that there's more ways and that you can kind of think outside the bag. And so there's ways that you can suture lenses, you can do sutureless techniques, there's iris fixation, you can actually save old IOLs using suture. And then don't forget that non-surgical correction is always an option. Contact lenses, spectacles, they can always help correct aphakia. And sometimes patients can see better with something like a contact lens. Dr. Lay talked about somebody with maybe corneal ectatic disorder, keratoconus. These intraocular lenses don't always do a great job of correcting for irregular corneal astigmatism. And so sometimes patients will see better with a contact lens. So what's the best type of lens to put in the eye when you can't put it in the bag? So the American Academy of Ophthalmology had a report that they came out with about 5 years ago, talking about the outcomes and safeties of all these different studies with all these different lens techniques, and they looked at all the different types, and different lens techniques had different complications, and the visual acuity, is fairly comparable between the different techniques. And the takeaway is that there's no superiority of any single surgical implantation technique when you don't have that zonular support. So, ideally, you put a lens in the capsular bag. That's probably the most ideal scenario. But when you don't have the zonules or the capsular bag support, there's really not one technique that you can say is the best technique. The one thing that we also get concerned about that the AAO report didn't really talk about is corneal edema. These anterior chamber intraocular lenses that are FDA approved, there's a concern that it's sort of very close to the corneal endothelium and maybe will cause corneal endothelial damage over time. And when you look at the studies, there's not really a big difference between these anterior chamber lenses and maybe these scleral intraocular lenses that you might fixate more in a normal anatomic location. And so I will still do interchamber lenses in the correct patient. So let's go back to the patient that I discussed. So this patient with the painless vision loss, he had a dislocated IOL. It looked like it was a three-piece intraocular lens. There's no capsule around the IOL, so you take a look a little bit closer. The capsule hasn't been dislocated posteriorly. And it looks like he actually has anterior capsular support, but there's a tear in it. And you can read the old operative note. You can see that there was a tear in the capsule, but there was good support for a sulcus lens. And this lens probably just kind of rotated out over time and fell to the back of the eye. And so what do we do in this case? So this is one of my really early videos during my fellowship. And so I start by kind of getting ready to do a vitreoretinal surgery. These are 25 gauge trocars. This allows me to access the back of the eye. And I'm going to kind of fast forward a little bit, but you can see the edge of this haptic kind of through the pupillary opening here in the back of the eye. And so what we do is we prolapse it up to the front of the eye and just kind of rest on the iris for the time being. I go back, do the vitrectomy surgery, make sure the retina looks healthy, make sure there's no retinal tears or anything like that. And then once we come back to the front of the eye, what I do is I inject a miotic agent to sort of bring the pupil down. And then I put these haptics anterior to the anterior capsule. So it's not in the bag. The bag itself, the posterior bag is not stable. And so I put it into the ciliary sulcus space. But I am concerned that maybe it's going to rotate back out of the space again, like it did after his first initial surgery. And so what I do in this case is I take a long needle with 10-O-proline, and I actually go through the iris, come around the haptic, and come back out through the iris. And what this is going to allow me to do is tie that haptic to the iris itself. So now the lens won't be able to rotate, it won't really be able to move. And it's already in that ciliary sulcus space, so the anterior capsule is still providing support, but the lens won't be able to rotate out of place. And so I do this on both sides here. And then I can tie a special knot. It's a sliding knot where I can tie it externally. And then I essentially pull it into the eye. And that will allow the knot to be secured. And I can do additional passes to sort of lock it down. And then I can prolapse this lens back into the correct space completely. And patients can do really, really well. And so, for this type of technique, the benefits are everything is internal in the eye. And so when we talk about potentially suturing in lenses to the sclera, you have a risk of external suture erosion or infection, but this is completely inside the eye. And so long term, it's a great option for patients that reduces risk of long-term infection. And this patient that I did the surgery on, he was really happy with his refractive outcome after the first surgery up until the IOL dislocated. And so I can save that same IOL and have a very similar refractive outcome. Some of the downsides are you can get a little bit of a misshapen pupil. You can get cystoid macular edema because it is kind of rubbing up against the iris. And then you can get pigment dispersion. And so because this IOL is right up against the iris, if you don't have good capsular support, over time that IOL will actually bounce back and forth, and it can cause the iris pigment to disperse, which can cause glaucoma and other issues. So what about suturing the lens? So there's no FDA approved lens in the US for actually suturing to the sclera, but we do have lens options available that have little eyelets or holes. These are some of the more common ones. The ones that I think are used a little more frequently are these three. There's a CZ70BD, which is a PMMA. It's like a very rigid lens. You have to make a big incision. There's the Bausch & Lomb makes the Acreos AO60, and then the MX60E, or now known as the EE lens, the Invista lens. And they have different materials. I personally prefer to use hydrophobic acrylic for any of my lens implants. It's a foldable lens. There's no risk of opacification of the lens, which we'll talk about in a little bit. The hydrophilic acrylic does have a risk of opacifying over time. And so here's one of these cases where I've done, this is also an early case of my fellowship. I do a little bit differently now, but I've done a pars plana vitrectomy. I have a bunch of ports in the eye, which I don't make as many port incisions. But this is that Invista lens, and I've cut off the haptics just to reduce the risk of it touching the iris. And then I thread this Gore-Tex suture through. There's different suture you can use. This is Gore-Tex. It's used a lot in vascular surgery. It's very inert in the eye. And it's very robust, so it doesn't risk breaking long term. And I have my suture orientations reversed in here on each side, and that allows the lens to be stable over time when you only have these two eyelets. And what I do is I make an incision. I manually feed all these sutures through the corresponding openings in the sclera. And then once I feed all these sutures through, I can manually fold this intraocular lens, put it into the eye, and then I slowly titrate these sutures with a slip knot until the tension is just right. I don't want to pull too hard on the sutures. I don't want to break the intraocular lens itself, this acrylic material, but I don't want it to be too loose so that the lens rotates. And so I carefully titrate the tension on both sides, do a slip knot, and then cut the knots, and I bury the knot to reduce the risk of the knot causing exposure through the conjunctiva in the future. So what are the complications? You can get IOL tilt. So if it's the suture placement is not perfect, your tension is not perfect, you can induce lenticular astigmatism if the intraocular lens is not in the correct plane. You can get lens opacifications, which I'll talk about in a second. And you can get haptic or suture breakage, and then you can get suture erosion over time. And so here's a picture kind of in the middle here where if you pull too tight, you can actually break these little eyelets in some of these lenses. And then depending on the type of lens you use, if you use a hydrophilic acrylic, if you use intraocular gas, or if they have inflammation or history of diabetes, sometimes you can get this permanent opacification of the lens itself, which you can't clean with a YAG laser, or you can't even polish off with the surgery. You have to explant it with the surgery. So what if the eye was a little bit dislocated, but the zonules are intact, and maybe this patient paid a lot of money for a premium lens and they're very, very happy with their vision? What can you do? And so you can do a similar technique where you still use suture, but rather than putting it through a brand new lens, what you can do is actually suture through the intraocular lens and capsular bag. So this is a case where the lens is a little bit dislocated. I do a conjunctival pertomy. I make sclerotomies or stab incisions using a 25 gauge needle. And I come up through the capsular bag right at the haptic optic junction, and I'll feed a Gore-Tex needle into the lumen of my 25 gauge needle and externalize it. And then I do the same thing a little bit more anteriorly, kind of in the sulcus space anterior to the lens and capsular bag. And what this does when I externalize this is I get a loop of suture around that haptic encapsular bag. And then I can just fixate that existing intraocular lens to the sclera. And I do the same thing. I do a slip knot. I carefully titrate the tension. You don't want to make it too tight so that you damage the zonules on the opposite side. And you can do this on both sides if you need to. So let's talk about a different technique. This is becoming more and more popular in the United States, and it's a sutureless technique where you use an intraocular lens, a three-piece intraocular lens that usually generally has either an acrylic or a silicone optic. And then the haptics are made of different materials, either PMMA. There's one lens in the United States that's made of polyvinylidene fluoride, PVDF. That's the one made by Zeiss. And what you can do is actually, rather than using suture, you put this lens inside the eye and you just pull the tips of the haptics out of the sclera. And so you just have two little spots there poking out of the sclera, and the lens is supported on its own without using suture itself. And so in order to pull the haptics or the arms of the lens out of the sclera, you can use needles, usually a 27 gauge needle or a thin-walled 30 gauge needle that generally will fit that haptic perfectly into the lumen. You can also use trocars. I showed you a little bit about retina surgery, these kind of ports that you put into the eye. You can use these ports to pull these haptics out. And then a lot of these lenses that we have in the United States, you can actually use low temperature cautery and you can melt the tip of the haptic. And what that does, it creates a little bulb or flange, and that can help reduce the risk of that lens haptic being pulled back into the eye so that it stays more stable. And then one lens I didn't put on here is the light adjustable lens. That's a new lens that came out, over the last few years. And there's been a lot of talk about, oh, can you actually use a light adjustable lens as a three-piece lens? Can you use it off-label maybe to do the scleral sutureless technique in somebody that doesn't have capsular support, and then after the surgery, fine-tune the refractive outcome? And so one thing to keep in mind is that these lenses, they are generally about 13 millimeters from haptic to haptic. And when we're fixating it to the sclera, we're generally putting these lenses under stretch. And so in people that have very, very large eyes or very large white to whites, or I might be putting this lens on a lot of stretch, I may not use this technique, because the more you put the lens on stretch, the more likely you are to damage the lens itself or to have some instability in the lens placement for this type of technique. And so in patients that have really, really large eyes, I might actually use suture or a sutured technique, because I can make the suture as long or as short as I need to accommodate the eye. And so here's this technique. This is a patient that's had a previous vitrectomy already. They're aphakic. They didn't have any capsular support. And I take a 27 gauge needle and I go through the sclera about 2 millimeters posterior to the limbus. I tunnel it a little bit. So it's not a straight stab incision, but I actually tunnel through the sclera a little bit. And I insert this three-piece intraocular lens with these thin haptics, and I dock it straight into the needle. And then as I inject the lens, I might guide it a little bit more into the needle so it's nice and secure. And then I'll externalize the needle. And I use this low temperature cautery to melt the tip. So this will prevent it from retracting as easily back into the eye, so I don't get a dislocation again. And then I can do the same on the other side. Here, this is a lens that has the PVDF haptics. They're very, very resilient. And so you can really manipulate them. And so here I'm actually docking it outside the eye. You can't be this rough with some of the lenses that have PMMA haptics. And so once you do the second haptic, you can externalize it, do the same thing, create a nice little flange, check this flush against the sclera, and then you retract the conjunctiva back over the haptics. And these patients can also do very well. This is more of a technique that I do now. This is a trocar-based technique. So this is a patient that had a very, very complicated surgery, had iris loss. I later had to reconstruct his iris as well. He's had a vitrectomy here. I'm going and marking the same spot about 2 millimeters from the limbus. And here, instead of using a needle, I'm going to use a 23 gauge trocar. And so retina surgery has gotten smaller and smaller. And so these purple trocars are 27 gauge. And it's just a little laparoscopic port. And what I can do is I can go through these ports and either use a needle or forceps. Typically, most surgeons will use forceps using this technique, but here I'm using a needle, so it's a little bit of a hybrid technique. And I'm doing the same thing. I'm docking this lens in. And then I externalize my needle, externalize this little trocar, and we have the same outcome as we had before. We have a little haptic comes out, we flange it. But in this case, I'm actually going to internalize the entire lens. And this patient's had a full pars plana vitrectomy. And then I'll grab that lens with forceps and externalize it through the trocar this way. And so you can put a lot less stress on these lenses that way, and really be a lot more gentle with the fixation technique. And so when you look at sort of the outcomes of this is looking at the outcomes for Dr. Ash Abbey. He's here in the Dallas area. He's also a vitreoretinal surgeon that does a lot of these. What are the outcomes when you do this technique? We found that the patients do really well, but when you do flange the haptic tips and create a little bulb, you're much less likely to have dislocations. When you use smaller gauge instruments, so 27 gauge trocars rather than 25 gauge trocars, you're much less likely to have late dislocations after your surgery. You're much less likely to have hypotony, probably because the trocars don't leak as easily. And when do these cases dislocate? When you use an existing IOL, an existing lens, and you're trying to save it, you're more likely to have dislocation compared to if you put a brand new IOL on. That's probably because if you're using existing IOL, it might have capsule on it. You have to sort of clean up the lens to be able to use it. Maybe the lens was already damaged from the initial surgery. But there is still, a rate of dislocation. So you have to be very careful about how you select for these patients, what type of lens you use, whether or not you use the same lens or put in a new one. And then there's this not really well understood phenomenon called reverse pupillary block, where you can get unequal pressure gradients between the front and the back of the eye. You can get the iris capturing with the optic. So the optic could be in the anterior chamber, and then the iris kind of comes behind it. You can get glaucoma, increased pressure. And we found that when you do a peripheral iridotomy at the time of the surgery, or you can do it preoperatively with like a laser or postoperatively, you really reduce the risk of this complication. So most of these patients, I will do an iridotomy. And so really use small gauge instruments, use an iridotomy, and be careful about the manipulation of the IOL. So what about refractive targets? We talk a lot about having good refractive outcomes. That's becoming more and more important with these new generation lenses, which are giving patients very good refractive outcomes. Typically, when you're at the zonular plane or in the bag, when you look at your IOL biometry, you're using the bag calculations. When we're putting a lens into the sulcus and the lens is a little bit more anterior than it would be anatomically, you're typically decreasing the IOL power and aiming a little bit hyperopic. And if for some reason you're going to be posterior to the zonular plane, you might aim a little bit more myopic. And so when I'm doing these scleral fixation techniques, I'm probably a little bit posterior to where the lens would truly naturally sit in the bag. And so I do aim a little bit myopic. I generally target somewhere between half a diopter to 3/4 of a diopter of myopia for these scleral fixation. And I always counsel these patients that they are going to require glasses postoperatively. I generally try to under-promise and over-deliver, and my patients are usually pretty happy. But the reality is that there's really not a great consensus on what the refractive outcome will be. There are some surgeons that target exactly plano for the lens calculation, some that go a little bit myopic, but when you look at the outcomes, it's sort of all across the board. And so talking more about refractive targets, what about if they have corneal astigmatism? You can do a limbal relaxing incision or an arcuate keratotomy incision and try to neutralize some corneal astigmatism that way. You can use a light adjustable lens. We talked about that a little bit potentially to maybe correct for some astigmatism post-operatively. But what about a toric lens? Can you put a toric lens in? And there are some people that will put toric lenses into the eye. And so this is the same Invista lens. And people have recorded different outcomes with this. And they've had pretty good success with fixating this toric intraocular lens to the sclera. This lens, you can see the markings. The markings are pretty much right in line with the haptic-optic junction. So you can put the scleral fixation in line with where the astigmatism is. So this lens kind of works out that way. But what about other lenses? If you look at some other lens manufacturers, the plane in which the astigmatism is neutralized may not be exactly where somebody might fixate it. So this is another study where they used one of the Alcon lenses and they actually sutured the haptics to the sclera and they adjusted for 53 degrees off axis to take advantage of the lens here. So the takeaways, there are a lot of different options for surgical aphakia correction. Every method really needs to be put into proper clinical context in terms of the pros and cons for that particular patient. And don't forget, as much as surgical techniques have improved, as much as I personally love doing surgery, surgery is not always needed. A lot of these techniques that I'm talking about, they work really well in patients, but we don't know how these patients are going to do 40, 50, 60 years from now. And so if I have a 20-year-old with a complex lens issue, I often urge them to be aphakic, to stay aphakic, to not suture in a lens, to not take the risk of potentially long-term complications. And I almost force them to do a contact lens trial. So I might do a surgery to maybe treat their urgent pathology, maybe remove their crystal lens or do a retina surgery, but I won't fixate a lens, have them do a contact lens trial. And I would say about 95% of my patients that are young tolerate contact lenses great, are very happy with their vision, and I don't need to do something more invasive like a surgery. Thank you very much for your time. Thanks for spending your Saturday with us. This is my email here. If anybody needs to reach out, just my first dot, my last name at utsouthwestern.edu. So let's get into the post-test clinical vignette. So again, coming to patients aphakic, there's a patient that presents with a complication from cataract surgery and it's aphakic. What's the best technique for aphakia correction? Would you do an anterior chamber intraocular lens, a scleral suture fixation of intraocular lens, maybe a scleral sutureless technique? Would you do a contact lens, or does it really depend on the patient as each option has its pros and cons? All right, so here's the results. I would say my personal preference is it really depends. Every option has its pros and cons, and I think most people would agree with that after this talk. In some people's hands, the scleral fixation can work really well, and it can work in most patients. But I think we really have to take a holistic approach when we treat these complex scenarios. Thank you very much. All right, so thank you for all the panelists today for presenting their sort of niche talks on all these topics. Thank you for all the audience members for taking a Saturday morning to spend time with us. Please remember to get your CME or CE certificate. You have to attend the entire webinar, which I think most of you all did, looking at the audience members. And please complete the brief evaluation, download your certificate using the link that will be provided at the conclusion of the program. The link will be emailed in 24 hours, and then it should be open through May 15th. And so you'll have plenty of time to be able to complete this and get your credit for it. But thank you again, everyone. Have a good day.